name is Dr. Respicious Boniface. I'm the Executive Director of Muhumbili Orthopaedic Institute. My job today is to do a welcome note. Welcome to today's sessions of our 7th Neurosurgery, Neurotrauma and Critical Care course, conducted for the first time, I think, via Zoom. This is due to coronavirus issues. Thanks to organizers, Prof. Roger Hart and the team, MOI team, for making this happen. Today's theme is international research collaboration, how to get started and succeed, which is very, very important, especially in low-income countries like our country, Tanzania. So our first session's moderators are Dr. Shabani and Dr. Zarina. So please welcome and thank you very much.
Thank you very much, Dr. Boniface, our CEO, Muhumbili Orthopaedic Institute. So to make the ball rolling, I welcome Dr. Beverly to present on our presentation.
Sorry, I've just appreciated I was mute, so I'll just take it back. So my name is Dr. Beverly Chesaram. I'm the assistant professor in Aga Khan University Hospital and previously the Weill Cornell Global Health Fellow based at Muhumbili. My talk will be on hands-on training in neurosurgery, residency, and in its aspects within patient safety. So training in the 21st century is very different from training in the 20th century. Neurosurgery is an apprentice model of training with a master surgeon principle. The picture on the left depicts Harvey Cushing with his apprentices. It was often not time limited. It was more to do with skills acquisition, and the training was largely by patronage of finance. The field was largely male dominated, and there was a very patriarchal decision making where the doctor knew best and advised. And patient dignity and privacy, as you can see in this situation, was not of the utmost importance at that time. But we roll on now, and the face of neurosurgery is changing quite rapidly. It is still an apprentice training model. There's still a master surgeon principle. The picture on the right depicts Mr. Shabani, Dr. Shabani, who's actually quite a master surgeon, particularly in endoscopy training. And whereas previously it was not time limited, there is now time limits in almost all neurosurgical programs across the world. And they vary between 3 to 8 years with a variable competency level. The training is still largely by patronage or financial ability. What does this mean? Whereas previously patronage may be a rich family, we're now still in the guided by institutions or the ability of our families to finance our long training program. This can be a challenge in low and middle income countries because the training is quite prolonged, so a 3 to 8 year period. And therefore, one of our surveys that we did, in Africa, where we looked at 130 neurosurgeons who are in training, about 20% are self-financing. It's still male dominated, but there's an increased female recruitment. Now, what this means is that there's an increasing preponderance to 2-income family homes and the dynamics that means for their family situation and the need to look at what you do during the working hours as opposed to longer training days that may not necessarily suit the family dynamics. It's no longer patriarchal, it's more patient-centered. And therefore, our role is to educate the patient and often on the variabilities of treatment options, modalities available, and for the patient to choose for themselves. And patient dignity and privacy is paramount. This has significantly changed our ability to operate certain aspects that, for example, traditionally, how we undertake surgical exams, or who could be in theater, we now have to be very sensitive to the privacy of the patient and ensure that they're included in the decisions, including those of training. And we have increased measured outcomes and patient safety. This is not necessarily true for the whole world, but it's increasingly appreciation that the patient outcomes need to be published, publicized, and available even to the trainee. So the face of African neurosurgery, Key Park and et al. Pointed out that there are 5 million operations that are unmet worldwide, and these were neurosurgical procedures that they were principally looking at. Africa has a 1.4 billion Africans with only 2,500 neurosurgeons, most of whom are concentrated in North Africa and in South Africa, which means the middle bit, the East, West, and South, is not only, so the East, West, and Central is not only vast geographically, but has a low neurosurgeon to population ratio. This means that there is a public health crisis of unmet surgical needs. 50% of our operations are emergencies. There has been a rapid expansion of neurosurgical training. 20 years ago, most neurosurgeons had to leave their respective countries, but now we have several WFNS centers in South Africa, in Kenya, in Morocco. We have large training institutions such as Senegal and many other institutions. For example, Tanzania has its own that not only trains Tanzanians, but also neurosurgeons from the region. However, because there's a rapid expansion, it does mean that many African neurosurgeons are pioneer surgeons. They're going into systems that are not developed at all for spine surgery or neurosurgery. And therefore, they not only have to figure out their technical expertise, but also their management, and put in the relevant strategic management to be able to run their institutions. That can have implications for their ability to give time to training. Advanced pathologies at presentation and with fewer resources mean that the training models that may be used in many international organizations may not necessarily completely relate to a low-income setting where the patient may already present at a very advanced stage, and therefore there needs to be a certain mastery and flexibility to how the training model is designed. There are very few surgical companies based in Africa. This is pertinent because many of the surgical companies are those that sponsor training. So therefore, we have to look beyond the bedside teaching model and explore other opportunities that we may use. This may include cadaveric or using simulation models. For example, in the middle, that is an extraventricular drain model, animal modeling or simulation skills lab or situation skills lab, or even the adoption of other technologies such as AR and VR. What are the challenges and the opportunities presented? If it's cadaveric, it does give true anatomical representation, but it is particularly high cost and there's need for tissue handling license. There's need to understand the local cultural legal acceptability of cadaveric models, and they need to be specifically preserved to be suitable to undergo neurosurgery and spine modeling surgery. We can look at animal models, 3D models, low fidelity models, which can be cost effective. They require no special licenses, but they don't necessarily represent true anatomy. And then we have the option of augmented reality, which is new, and there's an increased uptake. There's an increased uptake of utilization of IT within the African context, but they may be costly in terms of its software, and the haptic feedback is limited. So these are some of the situations that you can use for simulation training. These are about critical skills that can be translated into the OR setting. So, and here we've just listed some of the opportunities that can come from them. This can either be either in pre-hospital management, such as basics, ATLS, or advanced life support models, or it can be in theater, or it can be about teamwork modeling and situational awareness. And this is just a list of some of the equipment you may need. But what do we have at the moment? So I spoke to several neurosurgeons in multiple countries. There's still a paucity of ability for skills training or cadaveric access within our region. We are covered by the COSAXA region, which is 14 countries, and that only has one mobile training simulation lab. So therefore, even though we realize there's a need to go beyond training with training within theater, there is a challenge in access for the neurosurgeons in our region. And the challenges are ubiquitous. It's a lack of funding, shortage of equipment, and lack of trained staff to run the skills laboratory, particularly in cadaveric models. The clinical activity will always outweigh the training time because we have lone surgeons or very low surgeon to the population need and limited training opportunities post-residency. The opportunities come with regional collaboration. So perhaps under COSEXA or many other of the umbrella bodies that want to partner with us, we can have training centers that will allow trainees from around the region to come to the same place to use a simulation lab. We need to form partnerships with institutions that have developed simulation and cadaveric training and creation of low fidelity models. There is an increased uptake of smartphones, so models that can be used to train will not only allow flexibility of timing for when the trainee can undertake the particular relevant skills, but also it makes it much more accessible outside of the national centers, which is where many of the specialist surgeons are available. We need to adopt technology such as Intersurgeon, Proximy, Zoom, or Skype that can facilitate remote mentorship. In this particular note, I would like to highlight the MOI and Cornell partnership that involves weekly meetings to discuss cases. And this has allowed continued mentorship, including the use of WhatsApp during the week to facilitate acquisition of skills in real time. And such companies need to consider investing in training in low and middle income surgeons institute. So overall, it all boils to one thing. We want the patient to do well, and therefore we need to look at what are our abilities, what are the things that we have, what are the needs of the trainees, and what are the resources that we have, so that in total we can improve patient output, patient safety. So I'd like to acknowledge those who shared their time with me in understanding what is available in the region for training. And let's not forget that although surgeries are still an apprentice model, we need to look for other ways where we can keep ourselves involved with our hands. Thank you very much for your time.
Thank you, Beverly, for a very enticing lecture. I think it stimulates discussion in the end. But before we reach there, let's invite Professor Rikin Trivedi from Cambridge University. He has a program running in Zambia, and let's hear from him what he does there and what advice he can give from what he's doing. Rikin, please welcome. Professor Trivedi. Is he around? Okay, we can go to the next.
He is a co-host.
Yeah, Rikin is not there. So let's move. Professor Oloch is absent with apologies. So let's move on to the last presenter, Ignatius Sen, who is going to present on research in low and middle income countries. Please welcome Dr. Sen.
Thank you so much for this opportunity to present this afternoon in the Tanzanian Neurotrauma course. I want to sincerely thank my friends Zarina and Shabani and Beverly for giving me the opportunity to be here this afternoon. So I come from Cameroon, and this is where I do my neurosurgical practice in the northern part of Cameroon, surrounded by Nigeria, Chad, Central African Republic, a population of about 10 million. As the pioneer and the only single neurosurgeon at the moment.
Problems connecting.
Oh my God. Sorry?
It's now.
Is it connected?
Yes, we can hear you. Probably.
Okay. Thank you. Yeah, and also I pick up an academic position in the northwest part of Cameroon, where I give lectures in neurosurgery and neuroanatomy. Today we are going to talk about three things. I'll give you an overview of the Young African Neurosurgeons Forum, the research opportunities and training opportunities for young African neurosurgeons. It's true that I have to talk about young neurosurgeons in low and middle income countries, but I'll prefer to focus on Africa for today. The Young African Neurosurgeons Forum is a very large group that comprises residents and fellows and consultants within 10 years of certification after training. And the aim of this forum is to represent and promote the interests of young African countries in all the 54 countries throughout the continent of Africa. Our mission is very simple: to promote, to improve on the neurosurgical practice in the continent through building of clinical and surgical skills, capacity building, mentorship, and in orienting our young neurosurgeons into appropriate subspecialty to improve on the practice of neurosurgery in the continent. This story started in Abuja in 2018, where we formed this young society. And since then, we've been building up the group. This is a committee within the Continental Association of African Neurosurgical Society, and we are linked to the neurosurgical societies in North America, Europe, and the WFNS Young Neurosurgeon Forum. We are now trying to expand the group and decentralize our activities by having people to lead in different activities, such as education, research, mentorship, and so on and so forth. So basically, our activities are quadrifold. We focus much on patient care, education and training, research, and mentorship. But how did we select these activities? This was based through a process of evidence-based neurosurgery. As I always say, decision-making in neurosurgery should be based on evidence-based neurosurgery, and policies should be defined based on evidence-based neurosurgery. So for us to determine our activities, we needed to, first of all, know our needs. So we did a survey in the continent, and we realized that most of the neurosurgeons have difficulty conducting and publishing research. They have educational difficulties, having access to educational resources, going for fellowships, and so on and so forth. So based on these needs, we define our activities. And we therefore offer opportunities to young African neurosurgeons to answer to their needs. So if you look on the left, this is the current situation where most of the young neurosurgeons focus more on patient care, doing surgery, because sometimes they are the only single neurosurgeon like myself, having to serve a very huge population, and therefore they are left with no time for research, no time for training and education of medical students or residents. But this is the picture on the right. This is what we want to achieve in the coming years: an equilibrated, or what we call academic neurosurgeon, where the young African neurosurgeon is not only going to be focused on patient care, but should be involved in training and education and on research. So there are many opportunities in education and research at the moment. You can find them on the WFNS website and on the e-hotline of the Continental Association of African Neurosurgical Society. We have opportunities offered by the WFNS Foundation for full training in reference centers. For example, we have the center in Rabat, we have in Egypt, we have in Senegal, South Africa, Kenya, and other African countries. There's also a center in Brazil for those who speak Spanish. And there are a lot of initiatives in the continent that promote training and give short fellowships, like the Africa 100 program by Professor Majid Semi, whom I was one of the beneficiaries. We have the China African project led by the president of the Continental Association of African Neurosurgical Society, Dr. Mahmoud Korashi. We have FINS chaired by Dr. Dempsey, and all other global neurosurgical initiatives. You can find them on the website of WFNS or the CAN's website. I will go focus more on opportunities within the continent, what we have been able to offer to our young African neurosurgeons. What are the opportunities we as Africans are offering to the young African neurosurgeons? Of course, supported by international organizations. We begin with as regards research. The first thing was to build capacity, as we saw that one of the greatest needs of young African neurosurgeons was inadequate resources to research and publications. So therefore, we started with capacity building. The first course which we had in 2019 in Kinshasa, which was heavily attended by even with the presence of the president of the WFNS, Professor Franco. So after this, we had other plans to have courses in all the regions in Africa, but unfortunately, COVID-19 came in. But we have re-strategized, and in the coming months, we are going to have more courses in capacity building with vis-a-vis research. Building capacity. Next thing we had to do was maybe to look at get resources for young African neurosurgeons to publish their research, because in the continent at the moment, we don't have an African Journal of Neurosurgery. So therefore, we needed to create relationship with other journals to permit our young neurosurgeons to be able to publish their works. We founded the Pan-African Medical Journal Clinical Medicine, whom are one of the founding fathers. There are possibilities for young African neurosurgeons to publish with waiving of the publication fee. We also work in collaboration with the Egyptian Journal of Neurosurgery to promote research in the continent. Recently, we also tried to work with other journals. For example, recently there's a call for papers to publish in trauma. We know trauma is a public health problem in most African countries. And I want to announce that here the publication fee is going to be waived for researchers from low and middle income countries. So this is an opportunity for young African neurosurgeons to benefit from. We've also worked with so many journals like the Frontiers in Surgery, and it's a special issue which is coming up soon. Abstracts are accepted in December, and the full paper should be accepted by April. The focus this time is going to be on global health problems like TBI again, hydrocephalus, and so on and so forth. So we are calling on our young neurosurgeons in low and middle income countries to send in their papers. We didn't end here. We've been trying to work with other journals, but we need a space where young neurosurgeons in low and middle income countries can actually publish their work. A journal owned by researchers in these countries. That's why in the past few months I've been working with KPAC, this James Rutger, trying to build a journal which is going to serve the interests of researchers in low and middle income countries, which this is going to announce in the coming months. We also encourage collaborative research in the continent, and before the advent of internet or the facilitation of IT facilities, it was difficult for people in different countries to collaborate to do research. But in recent years, with the presence or with the ease with which we can use internet, it's possible for us to do multi-center studies, as exemplified by this one, which was done by young neurosurgeons in many African countries. Again, this is another paper that illustrates the possibility of African countries collaborating together to produce results that represent the image of the country. And this was a paper led by one of our colleagues, Beverly, who is a young female African neurosurgeon. And this is actually the first continental paper published by the Continental Association of African Neurosurgical Society. So you see, it is not impossible. It is possible for us to come together and produce work that is going to represent and reflect the clear image of what is happening in the continent of Africa. Initially, we started with fiscal courses, but with the advent of COVID, it was difficult for us to be able to continue. Everything was stopped. So we definitely needed to re-strategize and adopt new means and methods to be able to continue with education and training and with our research activities. So therefore, we thought we shouldn't be lamenting about the advent of COVID. We should instead look at the opportunities which we can explore and exploit for the benefit of our continent. So therefore, we started with online courses. Okay, we had the first online course with the research methods, where we invited Professor Benzel to continue. And as I told you before, in the coming months, we are going to have many online courses on education and research. Things changed when these two ladies joined the team, the team of the education of the young African neurosurgeons, and they actually revolutionized the way we do things. So we have had now a very perfect forum where we have organized at the moment about 4 online courses. And here we are able to bring in all young neurosurgeons within the continent to showcase what they are doing, to showcase their research work, to showcase their clinical practice for the world to know exactly what we are practicing in the continent. And this is a very good opportunities for young neurosurgeons in the continent. And if you want to contact them, this is the email address which you can use, youngafricanneurossurgeons@gmail.com or youngcans@gmail.com. If you contact them, they'll be able to insert in one of the courses and you can present or moderate. So this was the first course which we had, which was on hydrocephalus. It was highly attended. And we have gone further to ensure that the course is of good quality by ensuring that it is accredited, okay? And these are other opportunities which many young neurosurgeons can benefit from. For example, they learn how to moderate a session, they learn how to do academic presentations, how to talk in public, large-scale communication, and so on and so forth. So we have been able to invite very renowned speakers across the world, like Professor Chooks. We had here Dr. Shabani, who showcased what we are capable of doing in Africa. So we're encouraging many other young African neurosurgeons to come in and contribute. We're quite open and encourage everyone to come on board. We've been collaborating with other organizations like FINS And last month we had the first course with the Sudanese group, and we are going to extend it from Sudan to Central Africa and other African countries. So these opportunities, and during these courses, we invite many young African neurosurgeons to come in and learn from masters in different fields in neurosurgery. What about opportunities and training for people who want to get into neurosurgery? There's a very good association in Africa known as Association of Future African Neurosurgeons. So you can contact them. They are going to tell you how the different training, how you can get into neurosurgical specialty. And they have been doing so much work in the continent, enormous work, excellent work in terms of education and training. And therefore encourage all medical students who want to get into neurosurgery to contact them through their Facebook or Twitter accounts, and they'll be able to mentor and guide them on how to get into neurosurgical training. These are our contacts. If you want to get much more information about the Young African Neurosurgeons Forum and how the opportunities we offer for young neurosurgeons, you can contact us through our Gmail account, contact us through Facebook, Twitter, and Telegram group. Thank you so much.
Thank you very much, Dr. Esen. That was a fantastic talk. I am privileged to know the two previous speakers, Dr. Beverly and Dr. Esen, as some of the very active young African neurosurgeons who are widely traveled, and they represent the continent in a lot of educational activities. So it is true what Dr. Esen just said. The Young African Neurosurgical Forum started simply as a WhatsApp group, but developed into a very big group that joined a lot of young African neurosurgeons and trainees all together. And right now it is spread throughout the social media, as he pointed out. So we welcome if there are any questions to any of the two presenters.
So
for the moment,
my name is Halman Gatt. I work with Dr. Hartl on the TBA collaboration at MOI, and last week we had, or 2 weeks ago, we had a session inviting any young neurosurgeons in Africa who are interested in, we're trying to put together a group of people who want to dedicate their efforts into TBI research, and we would be willing to sort of provide the platform as we have at MOI, lessons learned, and provide statistical study design, input into trying to actually put regional data together, then everybody doing something different to identify common issues to address. So Dr. Beverly is, if anyone's interested, Dr. Beverly is the contact person. In addition, I just want to say there's a group of people working out of University of Michigan, and I volunteer my time there as well, where they can, they help put manuscripts together, finalize manuscripts. So if somebody's interested in submitting a scientific manuscript, you can send it to this group. They'll review it and help you, especially if you're new to it, to finalize it. It's free of cost, it's voluntary. The group is called PrEP, so I just put their name in the chat box. Thanks.
Thank you so much for the information.
I can see Dr. Trivedi is ready in. Can you continue with your talk?
Yes, I'm so sorry. It's complete stupidity on my part. Please accept my apologies. I was preparing myself for 5:15, and I hadn't quite adjusted the time difference. So apologies. If it's convenient, I can get going.
Yeah, sure. Go ahead.
Perfect. Okay. So I was asked to sort of just run through our Zambia experience that we've been involved in now for the last few years. Most of you will recognize the Cambridge contingent has been contributing to some of the stuff out in Tanzania as well over the last few years, but we have had separate experiences in Zambia and in the wider sense, the low middle income belt. And our approach has been a sort of similar sort of approach to Cornell in terms of addressing research deficiencies. But I think unlike Tanzania, Zambia has been a bit more infant in its neurosurgical trauma training and capabilities. So we've sort of been trying to resurrect that to a level which is appropriate for training next generations. And I thought I'd just talk through that. I mean, we come from a very strong research pedigree in Cambridge. We've been heavily involved in neurotrauma research from decades now, with measuring ICP and ICP-based interventions, improving outcomes. We recently run the Rescue ICP study. We're involved in a chronic subdural very large-scale trial, and more recently in a very large European grant in conjunction with the Belgian group, Centre TBI. So our research pedigree has been very good in the wider sense, and more recently we've been broadening our research repertoire into aspects that perhaps low middle income countries don't necessarily get exposed to.
Me, Dr. Trivedi, we don't see your screen.
Okay, hang on. Let me share screen again. Apologies. Do you see that now?
Yes.
Yeah, okay. So these are, I mean, just to run through our sort of research pedigree to date with the various studies around the world. But we haven't historically been involved in research involving the low middle income belt until a couple of years ago when we set our stall out with the GENOS study. Many of you on this meeting will be contributors to, and the results of that are in submission for peer review. So we should have that in the public domain in the coming couple of months. But it was really sort of a chance event in terms of propelling us in this sort of domain, with the publication in 2017 of the sort of Lancet Commission data on TBI in terms of worldwide burden and the sort of impact that emergency surgery has in improving outcomes, and particular deficiencies in access to that sort of surgery in the low middle income belts. So we focus our efforts in TBI in that sort of economic group, and we were very successful with an application to the British research authorities in setting out a study proposal to look at emergency surgery for severe TBI around the world in this group. And that's what the GENOS, one of the things the GENOS spine is an output from. And what we set out to do is involve as many of the low middle income sort of belt across the world, from Africa, Southeast Asia, South America, and sort of the Pacific, to be involved in the design of this from the outset, just to sort of get an idea of what the research capacity was in these environments, and what additional infrastructure would be welcome to further that. And with regards to Zambia, again, serendipity underpins a lot of the research output that occurs. And this was another sort of chance event. I'd sent out one of my medical students to do an elective at the Beit-Cure hospital in Lusaka. This was when we had this sort of interaction with the guy next to him, Dr. Sichizia, who some of you will recognize, who's a neurosurgeon by training, was working in the Beit-Cure hospital. And he sort of reached out to us via Manteg here, saying, you know, is there something we can do in a more consolidated way to build neurosurgical training in both the research and clinical aspects in Zambia? And that's what started our sort of interest there. Zambia is obviously quite a large country with a very diverse geographical sort of extent in terms of its east and western borders, but it's not as populous as many and in the region, and it's relatively underdeveloped in many respects. As far as neurosurgery in Zambia is concerned, there are now 3 government-funded neurosurgeons in Zambia, one having recently returned from training in Kenya. And there is a Russian who sort of, I guess, migrated over there a few years ago that works out of a hospital near the Victoria Falls. It's a very small hospital, and he's essentially a trauma surgeon without any other neurosurgical practice. There's one orthopedic spine surgeon, South African trained, Zambian in origin, who looks after all of the spinal cord injury type work in Zambia from all over the country. But they had no real infrastructure for training there. And it was not until we sort of got involved, we helped them develop a training program, which was then funded nationally, and now is in its running into the 3rd year come January, with residents who are going through a training program within Zambia, in addition to those that may well want to join the COSEXA, which is obviously a well-developed training program within the African subcontinent, or continent rather, as well. And so that's sort of from its infancy where training started, and it has evolved in many respects. To sort of tapping into the research capacity, this is very much in the ethos of the University of Zambia, UNZA's sort of mission statement, to continually improve and innovate. And this was something that resonated very much with Dr. Sachizia and the superintendent of the University Hospital there. And it provided an environment for us to then look at ways in which we could help them advance and innovate in terms of both educational resource for clinical training, but also research capacity building. So we've had a number of visits out there. We've run weekly sort of teaching type interactions via Skype. It has been until the advent of Zoom becoming more available to the Zambians there. We've stuck to Skype. We've donated equipment like many of the first world countries have, but we also funded a number of individuals to build on the research infrastructure there. And these 4 have been now in post for 2 to 3 years in various different aspects of research, collecting longer term follow-up data from TBI patients, TBI data itself, and now in terms of the ICU type data, and perhaps data also from the newly developed medical school at Levi Mwanza, also in Lusaka, as well as collecting some information on the spine trauma to help out the orthopedic spine surgeon. So we've set up both that global registry type approach and a localized thing. And so they, like many countries, have not been historically used to collecting their own data to monitor patient care or outcomes. And it doesn't require a lot from people like us who do this day in, day out. It's part of our own governance structures or appraisal mechanisms. But for countries where these sorts of things are not so ingrained, it is quite helpful. So we moved from a paper-based structure to something online through REDCap, as this was familiar with many there with the spina bifida type data that was being collected for the Bear Cure. And we've been regularly updating the registry with sort of quality assurance type mechanisms. But I think one of the things that is quite exciting for us is that we've been able to reliably capture longer term follow scan, and you can see actually most people that make it to the university hospital are able to access CT imaging to rule out very severe injury. And we can see actually many of them will go on to survive despite the sort of nature of the injury. And not all of these severe TBIs have ended up having surgery. So interesting sort of demographic data, but we've also now as I've alluded to, managed to capture some longer term follow-up data.
Hey, Ricky, I think you're breaking off. We can't hear you.
I think we've lost Dr. Trivedi. Is anyone able to contact him?
I'll try to call him.
Are we back?
Yes, we can hear you.
Sorry.
Yep.
I myself live in a village. And so like villages around Zambia where connectivity to the outside world is poor, it's also poor in my village, so I apologize for that. What I'm saying is that we've started collecting longer term outcome data here, and that's actually really fueled the need in the sort of Zambian neurosurgeons themselves to think about the benefits of this, and it's really allowed them to continue this in a more concerted way. With regards to the teaching, we've had a sort of three-prong approach, like many, with a mixture of hands-on didactic, in-person and remote type interactions, and we've utilized social media type mechanisms, moving more towards Zoom-based stuff.
Sorry, would you share your screen, please?
Oh God, yeah, yep. Yeah, so it's a combination of remote and in-person based teaching, utilizing a lot of the social media platforms, like we are with this conference. It's lots now more Zoom based, but a lot of the Zambian residents and the neurosurgeons and spine surgeons are very much on their phones, and it's very hard to conduct these sorts of teaching sessions on a mobile phone. So we are still using and relying a lot more on Skype-based, case-based discussions and didactic lecture delivery, but it seems to be working quite well in terms of how they've received it. We've supplemented that with hands-on courses like the Tanzanian course in person in Zambia. We've run courses in TBI, in stroke, in pediatric and neuro-oncology stuff is the one that's next planned. But we've also brought the Zambian neurosurgical trainees to the UK for UK-based didactic and hands-on courses, and they've managed to take some of those skills back and use them in practice. In Zambia itself, we've been fortunate that Roger and the team and Phil have been going out to Zambia for more than a decade, and taking a team of individuals out there with you helps in a lot of different ways. We've gone out with ICU consultants like Hal, with nurse practitioners in neurosurgery, medical students and trainees, people with military background, all sorts of different ways of trying to increase the exposure, and that's been quite effective. And we saw that in Tanzania. We adopted the same model in Zambia. We've delivered various ways of teaching, and we've always questioned, you know, are we doing anything that makes a difference? We've seen the frustration. I've seen the frustrations myself. We go out year on year. We go every year. We think we make a difference. We think it's ingrained. We think it's going to be continued. But you never really know. We go the year back and things perhaps don't look like they've changed very much. And so I've always questioned, you know, the effectiveness of our teaching methods. I have an education background, educational theory background. And so I've always been interested in making sure the way in which we do things has some sort of effective output. And we've done various studies. And one of the things we did do, particularly in environments where they don't have access to hands-on, say, high fidelity cadaveric training, measuring the effectiveness of then didactic training is quite important. And one of the things we found in neurosurgery, of course, our knowledge of anatomy, operative approaches, narrow corridors is quite important, but it is actually enhanced when we deliver these things in low middle income countries using 3D technology more than the 2D stuff. And we've seen this in Africa, we've seen this in Southeast Asia. So I think measuring the effectiveness of the training and the research is quite an important thing for us if we are continuing to do these things. It's all well and good. We go out to East Africa every year. We feel good about it. We think we've made a difference, but have we really? And I don't think we often ask ourselves that question, but we ought to. Feedback is obviously very, very important. This is something that one of our trainees in Zambia has said about it. Self-assessment from the various courses, nurses have attended, physios have attended, and others around the hospital and the community where appropriate have come along. So that also modifies what we do. We try and put some science in this, and actually when we did try and put some science into it, we did see, both in terms of knowledge and confidence of neurosurgery and neurosurgical procedures for TBI, the way in which we deliver those lectures actually makes a difference. And this was published a couple of years ago. Sustainability is quite an important thing. You know, we go there every year. We are there for a week, maybe two. We do surgeries out there together. And we've done that in Zambia, as we've done that in Tanzania, we've done that in Malaysia and so forth. But how is it continued? And it's very important to get buy-in locally from the staff that are there, people that run the hospital, people that are involved in making health policies. And so right from the outset, when we were there in 2016, I spent a lot of time with the Dean of the Medical School in Zambia, with the Minister of Health, and it was very, very clear to me that this support for improving the research capacity, training capacity, came from the very top. And so having that government buy-in allows that to continue. And we've had media coverage there, and most recently with the stroke course that we run, the Vice President had been involved. So I think that leaves a legacy for us to allow the people that are there and whom we are supporting remotely to be able to continue and flourish. And that's an important thing. In terms of ongoing international collaborations, of course, it's something very much to bear in mind, that if you start something, you've got to have a sort of long-term view of what you're trying to achieve. And for me, it was very, very clear that we had to build some infrastructure there that allowed the local surgeons, the local researchers to then train their own. And we have some mechanisms within the UK, which I think is somewhat easier than in the US, to bring African trainees across to us, get them accredited without having to go through residency or any specific formalities, to come and spend 6, 12, 24 months with us in clinical training and also research training to then go back and train others. We have an ongoing research strategy, which has just gone for renewal, and we're hoping we'll be able to fund in the same way Cornell has, Duke has, and others, Vanderbilt have, in funding a sort of global neurosurgery fellow type appointment to allow exchange and to allow a continued presence for somebody from outside the LMIC environment to provide support for research and training. I've had one of my residents there for the last 2.5 years, who will finish his stint next February, and we're hoping that will be a seamless transition for that interaction that continues there. But I think these are very important to maintain that connectivity, both in a research domain, but also in clinical training on an ongoing basis. So that's all I was going to say about the Zambian experience. It's a two-pronged approach, and it's an ongoing thing, like we have in Tanzania. And I think thus far, from what we've seen, it's been quite a useful thing to bring Zambia back up to some of its neighbors in terms of its research and clinical training capacity. Thanks very much.
Thank you very much, Dr. Trivedi. Dr. Beverly had a question for you. Dr. Beverly, are you there?
Thank you very much, Mr. Trivedi, and thank you for an excellent talk. As pertains training, I wanted to ask specifically about non-surgical training. So this is towards nurses, anesthetists, therapists. What models have you employed within Zambia, and how much success have you had with that?
So we were out there recently with the stroke course at the end of 2019, and the year before with the trauma course. And on both occasions, I took specialist nurse practitioners in TBI and stroke care with me, and we had parallel symposia for the nursing staff, but also the physiotherapists that are involved in some of the aftercare for neuro rehab from the local hospitals, but also the more rural hospitals. And so there was a sort of a combination of hands-on training in terms of how to apply a collar, how to do log rolling, how to manage an EVD, aseptic sort of technique. We had paramedics that we took with us who had come from South Africa, who were doing more immediate care type training for paramedics or a paramedic training program that was in its infancy in Zambia. Again, a combination of didactic and hands-on stuff whilst we were there in person. What's been happening since those face-to-face interactions is that there's been separate dialogue, not as frequent, I would say, between our nurse specialists who've been out there and the heads of nursing in those various institutions, trying to develop or modify, let's say, existing nursing training curricula to bring them up to the best way they can possibly do so, both in terms of training, but also in terms of assessment. And so that is been, I guess, augmented with some collaborative research endeavors. They've just jointly, with the School of Nursing in Zambia, published or presented something at the International Stroke Conference about sort of stroke care, acute stroke care, identification within the ED department and moving to a stroke care type unit. So those are ongoing collaboration within the nursing communities, which I have not been part of, but they've been running in parallel. So again, I think there is a sort of similar legacy that's been left there to allow a collaborative approach to continue in the non-medical domains.
Thank you very much. Professor Hartle, you had a question?
Yeah, thank you so much. Thank you so much, Ricky. I'm happy you were able to overcome your technical difficulties. I live in a small village as well, and our internet access is better, but our hairdressers are not so sophisticated. So I had a question. You and the previous speakers did a really great job kind of summarizing the work that you have been doing and others on training and research development. And you've been dealing with the hospitals and the healthcare system in Zambia, I'm sure and it sounds like you've been dealing with them a lot and very intensely. What we've seen in Tanzania is that no matter how much research and outcomes-based research we do, it's very difficult to really attract the hospitals and the healthcare systems really attention. We thought that by showing that certain disease entities have very high mortality, for example, automatically the hospital would kind of notice that and try to change that. But that hasn't really been the case. do you have any advice from your experience? How can you really get the healthcare systems and the hospitals' attention to really implement changes when it comes to making investments into the infrastructure that will then have a sustained impact on outcomes? For spine trauma, for example, is the instrumentation, or for head injury, the ICU, monitoring, CT scans, MRI scans. In your experience, how can you change the attitude of the healthcare system, administration, and hospitals?
I think the short answer to that, Roger, is it's serendipity. It is chance to have politicians who are going to be swayed by that sort of data. It is chance to find individuals who think it's important on the local sort of front to instigate that sort of change. And we were, I guess, beneficiaries of that serendipity in two ways. One is that they had, after a number of years of what I think many people regarded as less than generous spending on domestic agendas, they had a change in government president who took a different view. And immediately what happened there was they were sort of minded to, if you like, tax the outside organizations who are benefiting from the country's natural resources. So Zambia has a very strong historical copper mining history, and the various big mining companies were forced to take out a levy to fund for healthcare infrastructure. And that was in the wider sense. So that funded 100 and something ambulances, but they realized that actually the ambulances couldn't go from the eastern province to the local large secondary trauma center in a quick enough time. So they used that levy to fund road building. They used that to fund a flying helicopter service, which was historically being used to manage uterovesical fistulae type things. So they were using taxation from whatever mechanism they could to divert to a domestic agenda. And that was a chance event. The second chance event was the chap who reached out to us saying, can you help us? Happened to be somebody who was very politically minded. He was pushing the agenda to develop neurosurgery as a recognized specialty within the surgery and physicians faculty within the healthcare department. He was appointed to some relatively middle level post perhaps in the Department of Health, the Ministry of Health. But he happened to work with a chap in the emerging department who happened to be the director of trauma for the whole country. And the other thing that happened is when we were there at that sort of time, they had one of the orthopedic surgeons seconded to the WHO for 5 years in Geneva. And he was the first to develop a plan, the local development plan as outlined by the Lancet Commission. So they had three individuals who had some political motivations, but were all surgeons and all interested in trauma, and more importantly, all interested in improving the welfare of the domestic population. And that was a chance event, I have to say. But that was fortunate for Zambia because it's allowed them to consolidate the ongoing lobbying to the government to keep this as an important thing on their domestic agenda. And I think that is what is ongoing. They're now obviously using a lot of the, like a lot of Africa, a lot of the Chinese financial resource to build infrastructure projects, but they are sustaining it themselves. So it was a chance event. I don't think from the outset, the data alone would have been persuasive, but now the data's come along, they are using that data themselves to push the agendas in government. So I think that's what I would say to that, Roger. It depends who is interested locally, and sometimes chance for having the politicians who are that way inclined as well.
Yeah, that makes sense. That also means so that data collection is important, and you don't have to do a prospective randomized study. Just collecting the outcome data as they are, which is what we're doing in Tanzania, could potentially be very helpful. You just got to find the right people to actually, pick them up and use them then in the right position.
One of the other things I would say is that we, I think, are very good. We are used to it in the Western world to try and connect the dots. We can see the bigger picture and how all these things can be important. What we found there is that actually the individuals don't necessarily link up automatically themselves. So the ED guys who are interested in trauma wouldn't necessarily be talking to the TBI neurosurgeons. The spine trauma guy, I can tell you right now, the spine trauma guy and the neurosurgeon who deals with head trauma, they don't talk to each other so much. What we've done is, I think, facilitate those discussions, because actually that's a natural skill for us to bring people. I mean, you're an excellent example of that, Roger, bringing people who are interested, who have certain expertise, bringing them together to make it work better together. And I think that's one thing we can do. To the extent, now we are looking at trying to answer the question for them, how much trauma is there? I mean, we can talk about the trauma that comes through the front door in the ED, that's managing the OR, that's seeing the ICU, but that's a select number of individuals that make it to the hospital. The larger number potentially is those that are dying on the street. But now there's a pathologist, the state forensic pathologist, who does all of the autopsies for people found on the street. And he's doing these and filling out pro formas saying, well, these I think are head trauma, these are spine trauma. So we, I think in a year's time, will have a truer idea of what is the burden within Zambia of TBI. And that's what they asked for. They asked, well, how big a problem is this? Is this really something all that we're seeing is coming through the front door, or are we finding people on the street dying of head trauma who can't get to the hospital enough because the roads are bad, the ambulance is no good? So they have asked for that data. And so I think you are absolutely right. Collecting that data, whether it's retrospective, run as a registry, or prospectively as some form of collaborative international study, all of it is very valuable, because in countries like Zambia and Tanzania to some extent, it's in its relative infancy as a tool to drive policy change.
Thank you very much. I think in the interest of time, we'll conclude this session. And I would like to invite the moderators for the next session, Dr. Magogo and Dr. Mbwambo, to take over. Thank you very much.
Thank you.
Thank you so much, Dr. Zarina. Actually, I'm going to moderate this session together with Dr. Emery. Dr. Mbwambo has an excuse. We have 3 topics in this session, and we'll be for a roundtable discussion. I introduce Professor Franco Savadei. He is the professor at Humanitas University and a research hospital in Milan, and he was the elected president of the WFNS, and he was also the past president of the Italian Society of Neurosurgery. He's going to give us a talk on the role of WFNS in promoting education and the research in LMIC. Professor Franco Savadei, you are welcome. The floor is yours.
Thank you. Thank my old friend Roger. We had a long story together of guidelines production and working together since at least 20 or more years. And thanks for the work you and many others are doing in Africa to help the development of neurosurgery there. With the worldwide scenario that we all know, it's related to a disparity. As you see it here, we do have...
Sorry for interruption. Do you mind if you share your screen?
Yeah, I am sharing the screen.
Okay. Okay.
You see it or not?
Right now, not.
Okay, I stop sharing and start it again. Okay, I start sharing. If you see it now, obviously,
yes,
we can see it.
Yes,
okay.
You can see it.
Yeah, okay, sorry. obviously it works when we try and then it doesn't work. It's obvious. Which is the worldwide scenario? The worldwide scenario for neurosurgery, we do have about 50,000 neurosurgeons all around the world, with large disparities according to distribution, and Africa and Southeast Asia are the most suffering part of the world, with less neurosurgeons than needed, and there are countries where we have more than we need. So it's a big disparity, which is shown here is we count about neurosurgeons available per population. We have a very high peak in Japan. Here is US and Brazil. Most of Europe is located here, sorry. And almost all of Africa is located in that part of the spectrum. So we do have huge disparities in the world, and we have also different facilities and instruments, but we need to do education in two parts. This is one of our ICU unit, which we call it full. You see one patient, one nurse, one doctor every 4 patients. This is what we call it full. This is in Southeast Asia, a number of patients who have been operated and are waiting for an ICU bed because they don't have enough ICU beds. Or this is a paper that we published recently about the use of isoscope, and one of these surgeons went to Benin to operate, and it's here, and the other one, there are 2 neurosurgeons from Milano operating in Benin and using the telephone as a microscope for magnification. So the same surgeon who published about the isoscope in Africa are using the telephone for magnification, or the same surgeon who are doing spine with navigation systems and intraoperative CT or arm are doing in Africa different surgery. So let's say fixation with old systems. So even surgeons from Europe, when they move, have a different possibility of working, as we heard now. The World Federation of Neurosurgical Society, and this is not my merit, because at that time I was not in the World Federation, was the first surgical society to promote full training, to support economically full training of African neurosurgeons in Africa. Until the 21st century, almost all African neurosurgery moved to be trained in Europe or in US, mainly in Europe, because of the language, and then many of them never came back. So my predecessors say the World Federation should encourage training in Africa, and we now have 3 different training programs running. One is a full program, as you see it here, is 5 years training, which is located, we will see, in many different locations in Africa, fully supported by the World Federation. Then we have a sort of fellowship for 3-6 months, and then we have what we call it a short training program in Europe, at least, for 4 weeks' time with only one topic. For instance, one surgeon wants to be more acquainted with endoscopy, and then it can come for 4 weeks. We support him and we train him specifically on endoscopy. These are the reference center for African neurosurgeon, the Rabat Center, the Recife Center, who is in Portugal, in Brazil for Portuguese neurosurgeon. We have the Kenya Center in Nairobi. We have in Senegal, in Zimbabwe, Algeria. These are the official centers from WFNS. And as you see from the paper that we recently published, about 21 trained neurosurgeons with support of the WFNS in Africa All of them came back to their own countries. You see that here there are most of the African countries. And in conclusion, we did help Africa by getting back to their own countries almost all the neurosurgeons we trained. So as already it has been shown, we had a very high increase in neurosurgeons available in South Sub-Saharan Africa, obviously not only due to the WFNS, but also due to the extension of training centers in Senegal, in Tanzania, as we have heard, in South Africa and related countries. We have many training centers, and we have increased the number of neurosurgery. But there is an issue. I only have 10 minutes, so I want to spend time in different topics as the one I have seen in the program. One issue is the publication. We do have the issue of how much we publish in Africa and how much we publish in the world, and where do we publish. And as you see, we have produced a paper together with the Cambridge University and together with the Harvard University, our group with them, about the TBI, the traumatic brain injury burden ratio in low and middle income countries. You see it here. This is you see the number of road traffic accidents we have in the world, and obviously the number of people who is injured by a road traffic accident. You see that most of these patients are South America, Africa, and Southeast Asia. And most of the publications are in Europe, as you see it here, in America, US, and some in Japan and China and Australia. So where are the trauma? There are no publication, and vice versa. This is what we publish is a ratio between incidence of TBI and the publication. And as you see, in US and Canada and Europe, there is an overwhelming number of publications, also in Western Pacific, meaning Japan, China, and so on. But if you go to Africa, if we go to Africa and Southeast Asia, the ratio is the other way around. We do have a lot of incidents of trauma and much less publication. The same is true for traumatic spine injury. This is the incidence of traumatic spine injury. Be aware, not from published papers, but from the data of the WHO, which is obviously more accurate. And as you see, most of the patients are in low middle income countries. And the other thing is true, exactly like for TBI, you see that this is the paper we have published, and you see that there is a reverse relationship between incidence of traumatic spinal cord injury and publications. Again, the same with very little publication in Southeast Asia and Africa. But I give you only one example, which Roger knows very well. Why it's so important to get publication for low middle income country. Talking about spinal cord trauma, there is in the Western world a large discussion about when do we operate the trauma, when we decompress the patient within 12 hours, between 12 and 24 hours, or late after a few days. Obviously, we can use magnetic resonance imaging, everything. So the discussion is early or ultra early. But the paper that Roger and his co-workers from Tanzania, from the same institute who is hosting us today, published recently, is telling us for the first time that exactly most of the patients are operated very late, and the time admission average is 6 days from trauma, and the mean time to surgery is 32 days. You may think that this is typical of Tanzania. No, I have reviewed a paper which was very recently published from Nepal, telling us the same thing, which only very few patients were treated within 7 days from injury. So we do have insurance status, economical factors, availability of implants, but the world is the same. 3/4 of the world are in this situation, are not in the situation of the Western world. And the lack of publication, high quality publication from low middle income countries is bringing us to a problem. Evidence-based medicine is produced by high income countries for high income countries. You see it here. This is British, that's Canada, this is US, or why? Because randomized clinical trials are done in Western countries. Only 8% of this study that also, again, we did together with the University of Cambridge and the Global Health Research Group show that only 8%, 8.8% of the randomized clinical trial were done in low middle income countries. So you can understand that the evidence-based medicine is located anywhere else. These are the two randomized trials on decompression, 100% in one study from high-income country, 91% in the other. So very, really difficult. How to improve the situation, I'm going to finish. As it has been shown until now, we need to work together. If we move, for instance, from evidence-based medicine process to a consensus conference with rules, obviously, in the consensus conference, we can host authors from Ethiopia, Tanzania, India, Indonesia, Nigeria, Pakistan, Vietnam, Haiti, Egypt, and so on. So we can enlarge the spectrum of the experts who are allowed. And then we have to start to discuss if the way in which we do the follow-up, which it is not possible in many countries of the world, is a real one, because this study from India showed that there is a very little difference in India between the discharge outcomes and the outcome at 6 months. Or if we can include the best centers from low-income countries in large randomized study. This is the Cambridge Rule acute subdural hematoma study, where the top recruiting center is Bangalore in India. So just to finish about something which is unfortunately affecting all of us, the pandemia. We say in Latin ex malo bonum, means from something very bad, we can have something good. And the worst experience of our life led us to have at least one positive message. Web-based education is free and can reach any neurosurgeon in the world. These are the messages I received a week ago after one presentation on the web. Uganda, Libya, Yemen, Democratic Republic of Congo. So these people has never been able to come, even some of them to go out of the country, but most of them didn't have the money to travel everywhere. So this, I think, is a message for the World Federation and for many of us. Web conference has to parallel with on-person conference and is here to stay. Then we have learned a lot from this COVID experience. This is not the topic of my talk. I tell all of you to visit the Neurosurgical Focus site on the next week, on Friday, where this issue, COVID-19 and neurosurgery, the full issue of Neurosurgical Focus will be of free access. And I can assure you that we have accepted paper from all over the world, from India to Indonesia to Africa, Egypt, many other African countries. So you will have in this issue a real good spectrum of what's going on in COVID and neurosurgery. So I finish with a positive message. We have learned something. We have learned that webinars are important and should not disappear after the COVID time. And we have learned that we need altogether to reduce the disparities. Thank you so much. Unfortunately, this is my seat in Milano now, and we all hope that next year we will be able to fly to Tanzania.
Thank you so much. Thank you so much, Professor Franco Savade. Such a wonderful talk. I can feel the vigor that you want to change this practice. And your talk has brought a lot of comments and questions in the chat box. I think all attendees, can you please preserve your question and comments till the roundtable discussion, which will follow shortly. May I welcome Dr. Emery to introduce Professor Hato, and welcome Dr. Hato for the talk. Please welcome Dr. Emery.
Thank you very much, Dr. Magogo. I would like to give a preamble on Professor Hato profile. Professor Hato is a neurosurgeon at the Weill Cornell Medical Center. He's one of the top 50 spine surgeons in the US, according to the Bakers, and one of the top 10 doctors by the New York Magazine. We have been working with him for quite a long time, and we have seen the changes in the management of the patients and the patient outcome, both of the TBI and the spine. So having said that, please, Professor Hato, you're welcome for the presentation.
Thank you, Dr. Lemary. Thanks for this very kind introduction. And also thank you, Franco, for being here and for giving this really comprehensive and inspirational presentation. I want to share my talk. I'm not sure if I can. You have to, you got to let me in to share the talk. Yeah, I'm not able to share my talk for some reason. Share screen. Oh, now I can. Okay. So thank you again, Dr. Lemary. My presentation will be on spinal trauma, and I was asked to give an update, an evidence-based update on the current research and clinical findings in spine trauma and how that may affect our management here, but also obviously in the rest of the world. Now, the role or the meaning of treating patients with spinal trauma surgically, the goal is obviously to preserve or restore neurological function, alignment, allow patients to be mobilized in an early way, pain-free mobilization, and prevent delayed neurological findings or deterioration. There are controversies, so there are a lot of interesting topics, and Franco and the previous speakers really touched on some of those. Surgical versus non-surgical treatment, early versus late decompression is always a hotly debated topic. And then other surgical controversies, front versus back, 360 surgery, fusion versus just instrumentation. We'll talk about that a little bit. So what I'm trying to do, I'm trying to give you like an overview over what has been published recently, and that may have an impact on how you treat patients with spinal trauma in your region. Now, in terms of fracture management, you have the options of non-operative treatment, you have the option of operative treatment. And if you decide non-operative treatment, the options of trying to brace versus no brace. The goal is always, regardless of operative or non-operative treatment, the goal is really to get these patients out of bed early on to mobilize them, because we know that that prevents secondary complications such as blood clots and so forth, ulcer development and so forth. And these things are sometimes very difficult to really determine in patients. There are a number of spine classifications out there, but my sense is that over the last 10, 15 years, really this classification has been the most useful, and it was recently updated by the AO. The reference is here. It's the AO spine, thoracolumbar spine injury classification system that talks about 3 different types of fractures: type A, type B, type C. Type A is really is the most interesting one in a way, because that's where most of the controversies in terms of surgical versus non-surgical treatment. Type B and C, for the most part, everybody realizes that those patients are usually unstable and will require instrumentation and surgery. But for some of the A3 and A4 fractures, this may be unclear. And that's an important thing for you to know, because you have limited resources, as we all know, and therefore you want to make sure that you use your resources intelligently for those patients who actually really need instrumentation, and not those who can be treated without surgery. Again, type A fractures involve the anterior column. Type B fractures involve failure of posterior and anterior tension band. And type C fractures are mainly fracture dislocation injuries, and those are obviously, for the most part, surgical. Now, how can you put all that together to come up with a treatment plan? I'm not going to go through all the details, but I want to point you to, for example, to this publication here. At the end of the day, you have to look at the big picture, and the big picture entails the classification A, B, C type of fractures. Plus, you got to look at the neurology. If somebody has a neurological deficit or is at risk for a neurological deficit, they're more likely to become surgical patients. Very important, what came out of this work was the importance of the posterior ligamentous complex. For that, you sometimes have to look at MRI scans, look at signal changes in the posterior ligamentous complex, because those signal changes are frequently associated with instability that may also lead you to surgical management of these lesions. And finally, pain. So you have to look at fracture type, neurological findings, PLC, and that again, you may need an MRI scan. Sometimes you can see splaying on X-rays on a CT scan that hint towards PLC disruption, and then pain. So you got to look at all those things. And we had Dr. Magogo and one of his colleagues, a neuroradiologist in New York a few years ago. And I remember very vividly that we went through hundreds of fractures that we gathered in Tanzania over the years and classified those fractures on the AO classification. And they did an amazing job, obviously, then with Andreas Leidinger and others to publish those results. What I find helpful is really this really old definition of clinical instability. This is by White and Punjabi, who really defined instability as the loss of the ability of the spine under physiological loads to maintain its pattern of displacement. So there's no initial or additional neurological deficit, deformity, or pain. And clinically, if I think about this, it actually helps me in my everyday life when I look at a spine to determine, well, do I think that this is actually an unstable or a stable injury? So the ability of the spine under physiological loads, meaning standing up and walking, to maintain the pattern of anatomy without causing a neurological deficit or deformity or pain. So I find that very, very helpful. Non-operative treatment, we talked about it. Some patients can be treated without bracing. Patients typically, obviously, they should not have a neurological injury. They should have a stable posterior column, very little kyphosis, very little loss of height, and very little canal compromise. And sometimes in these patients, a non-operative treatment may be helpful. Now, this is an example that we treated recently. There's a 14-year-old young boy who fell and came in with these multiple fractures. This is an A3 type fracture. This is the worst fracture. He's got another fracture here, a small fracture at L4. So the question is this patient unstable or not? So how do you make that decision? That patient had a lot of mechanical pain, was neurologically intact. We got an MRI scan to look at the PLC, and you can see here there's very significant signal change in the posterior ligamentous complex, which should make you somewhat suspicious. However, the fractures overall didn't look so bad. So we tried this patient first in a brace, and this is the patient lying down. We had him stand up in a brace, and you can see it becomes very kyphotic. So this meant for us clearly that this patient was unstable, and we treated him with instrumentation that we then are planning on removing after a year or so. So that's an example of operative versus non-operative treatment, and how do you come up with that decision? Another controversy is always timing of surgery. And Franco showed a nice paper. There are a bunch of evidence-based guidelines that have been published over the last years. This is a guideline that was published by the Neurosurgical societies in North America in 2019. Timing of surgery, looking at all the evidence, looking at all the publications, they found that that there was insufficient and conflicting evidence to really recommend strongly very, very early decompression. However, early decompression, and that was defined at 8 to 72 hours, is an option to reduce length of stay and complications. So not a very strong recommendation, but a mild recommendation to consider early surgery. Probably a stronger recommendation came from the AO, the guidelines paper that was published a few years ago, looking at central cord and spinal cord injury. And there was a recommendation to consider early surgery within 24 hours after injury, because there was some data showing that these patients had beneficial outcomes. However, overall, the evidence was low. For us, in where I practice, this translates also because of empirical evidence. It translates really into the decision that we will always try to treat these patients as soon as possible, because we have the resources, we have well-equipped operating rooms, we have the staff available, and those are other things you have to take into consideration. If you don't have the resources, if you don't have the infrastructure, then this may be difficult to put into practice. Nutritional support, similar to what we found in head trauma, also with spinal cord injury, early enteral nutrition is safe and should start as soon as possible. Thoracolumbar burst fractures, one of the more surgical topics that comes up. While do you always have to do an open instrumentation and fusion with putting down bone for posterolateral fusion, or is percutaneous instrumentation sufficient? And there are a lot of data showing now adding arthrodesis to instrumented stabilization is not always necessary, and percutaneous instrumentation is actually a good option. The question then arises, should you go back later and remove that? But this certainly means that, especially for MIS surgery, there's a strong argument to consider that, because the hope is obviously that you will decrease the possible complications from open surgery, such as infections and so forth. Pharmacology, you know the controversy about steroids. There are very weak recommendations now to consider steroids early on, within 8 hours after trauma. In these particular guidelines here from the CNS, they concluded there was really insufficient evidence. However, the AO guidelines still came out with a recommendation to consider the 24 course of methylprednisolone if a patient comes in within 8 hours of spinal cord injury. But overall, these are all relatively weak recommendations, and we will typically not give steroids at this point in these patients, unless they're otherwise totally healthy, young, and come in really, really early after spinal cord injury. A few more publications on pharmacological therapy. So this was the guidelines from 2013, the WFNS CNS cervical spine trauma guidelines. They spoke out against steroids in 2013. However, most of the guidelines also support hemodynamic and respiratory monitoring, and obviously resuscitation, in parallel to really what we have found in patients with severe traumatic brain injury as well. So, and this is just the background now that led us at MOI, together with Dr. Ruta, Dr. Shabani, and Dr. Lemeri, and many other of the neurosurgical and some of the orthopedic spine surgeons as well, to really start looking at spinal trauma over the years. And we started data collection back in 2015. That was with Andreas Leidinger, who was a fellow, a global surgery fellow from Barcelona, who came for 1 year and started together with the Tanzanian colleagues collecting these data. And that resulted then in the publication that Franco mentioned, where we found that the time to surgery was up to 30 days if those patients ended up having surgery. So that was a sobering finding. And then in a follow-up study, Scott Zuckerman, who was one of the following fellows, who's currently a spine fellow here in New York, he looked at this and he found that each day taken earlier to surgery offered a 4% increased odds of neurological improvement. And when he collected his data, still the time to surgery was 23 days. And then this resulted then in the attempt to implement a protocol to really take patients who are salvageable to the operating room as quickly as possible. We got through the Pew Synthes, we got a grant that paid for the instrumentation, the implants, and this really resulted in a dramatic improvement. Given the tremendous team effort and the team spirit and the support from the hospital and the surgeons and the surgical teams at the hospital, resulted in a dramatic improvement in surgery times from here 24 days to 2 days in some cases, and this is now being written up, these results. Now keep in mind that we also saw problems in patients, for example, with cervical spine injury who were taken to the operating room much earlier. Suddenly we saw an increase in complications. So these are really the fascinating things that come out of this type of research, and this is something that we have to obviously consider very carefully going forward. So in summary, I was trying to give you a little bit of an update about what's out there in terms of new findings or relatively new findings that will help you take care of patients with spinal cord injury, surgery versus non-operative surgery. I encourage you strongly to familiarize yourself with the AO classification. There's an app, there's a surgery reference app, I think it's called, where you can pull it up. Makes it really easy for residents, for attendings, for everybody to classify injuries, and that is associated then with treatment recommendations, not on the app, but in your clinical judgment in consideration with neurological status of these patients, the resources that you have available, the PLC disruption, and so forth. Timing of surgery, in my opinion, if somebody is hemodynamically stable, especially if it's thoracolumbar, you should try to really decompress and stabilize these patients as early as possible if they are salvageable, and if it can be done safely. With cervical trauma, you really got to make sure that these patients are tip-top hemodynamically stable before you take them to the operating room. And that's one of the lessons that we're really learning at MOI right now. Steroids, it's very unclear. Nutrition early on. And then most importantly, though, really what came out of this is you got to collect your own data, because that's the only thing that's going to help you then determine what are you doing right, what are you doing wrong, and what can you improve upon. So thanks for your time, and thank you for your attention, and I'm happy to answer questions later on, of course.
Thank you, Professor Hart, for the very elaborate presentation. I think you have answered the question which was asked by Professor Franco, because he had only one at the initial study by leading on the time of surgery among these patients. And now you have given the update, the changes which occurred after a period of time from the study done by Scott Zuckerman and the fellows, other people from MOI. So, so far the questions.
There's a question from the chat box. I think this was addressed to Professor Franco Savadei. Let me see. It was asking about the better time for time to surgery for better outcome. Let me read the question for you. What time is recommended for surgery of traumatic spinal cord injury patient for better outcome? I think this question was. Yeah.
I think. Well, I think Roger has already answered. He showed the complete revision of early versus late. So just follow him. I think there is a low evidence-based suggestion about early surgery within 24, 48 hours. But Roger has already answered.
Yeah, and let me just add that one of the really fascinating findings of this research is that, yes, it is true that you can improve outcome, but you got to be careful. With cervical patients who are potentially hemodynamically unstable because they have a high cervical injury, you may actually run into more complications if you treat these patients too early before they are hemodynamically stabilized. That's one of the lessons really that we've encountered in Tanzania, which is really something has not really been written about a lot, and considered. And maybe in other countries it's not an issue because these patients are being stabilized earlier and quicker. But that was a really important lesson to learn. So now, we have our Tuesday conferences when we discuss cases, and this always comes up. If somebody is there with a cervical spinal cord injury, should that patient go to the operating room immediately, or is it better to wait until they become more stable and then it's safer to do surgery?
I completely agree.
There's another question from Dr. Do you want to answer, Professor Mangat?
Yeah, I just wanted to add, emphasize what Roger just said is that I think, operating is the easy part in cervical spine, but I think that's where surgeons got to be a doctor as well, because higher spinal cord patients are going to have greater catecholamine need. That means you need specialized nursing. They might require pacing, transcutaneous pacing at some point. We have rarely placed transvenous pacers. Generally, it's required temporarily. And, even manipulating the endotracheal tube can produce profound bradycardia and a cardiac arrest. So operating and fixating this people is very easy, but having the nursing staff who can really do the perioperative care after this, which we take for granted, I think is very essential, especially if you're spending a lot of money putting titanium screws and plates and all the fancy stuff. That's a lot of cost. And if somebody were to die from a vagal attack during nighttime bathing when the patients turn, I think that would be tragic.
Yeah, there's a question from Dr. Alpha. This question is directed to Professor Hatton, and he's asking for a 14 years old boy with a longer segment fusion. What is your comment on the growing spine with the instrumentation? Will you plan to remove them before adjacent disease creep in? So he wanted the comment from this.
Yeah, this is a very good question. Yeah, in this particular case, yeah, we will typically try to remove the instrumentation, not only because of the age, but also because of the just the whole philosophy behind it. So what I will do is, this patient came in recently, but we'll get a CT scan maybe in 6 months or in a year to look at the fractures. If it looks like the fractures are being healed up, then we'll probably remove the instrumentation. In terms of the growth, these are very important questions with instrumentation in any child. And to my knowledge, there's no clear data indicating that instrumenting the spine really affects growth overall. But maybe somebody else knows more about that. But to my knowledge, the instrumentation doesn't impede with growth in these children.
Okay, Professor Franco, you have something to say?
Yeah, I've seen a message from one of the attendees about the role of South Africa. Obviously, as World Federation, we have full respect of the work of the South African neurosurgeon. The next 2023 World Congress of Neurosurgery will be in Cape Town. So we have many friends there, and we are very well connected. So we know very well the capacity of training and the capacity of publication in South Africa. Actually, I was focusing on the sub-Saharan scenario, where we do have much less possibilities to treat the patient. I didn't want to forget the role of South Africa in training and the role of South Africa in publication. That's out of discussion. As I told you, we will have our new Congress in South Africa. It's just because of the question.
Yeah, thank you, Professor Franco, for the additional information. Yes.
15 minutes for conversation.
Yeah. So we will have 15 minutes for roundtable discussion unless there is a burning question from the participant. We are also sorry to say Professor Kaladi is gave an excuse, so his presentation will not be presented. So we'll go straight to a roundtable discussion. So welcome, Dr. Beverly, for the roundtable discussion.
Thank you, Dr. Lamari. And so we're just going to go straight to the roundtable. It's a great privilege to have the speakers that we have, to have Professor Franco Tabade with us, Professor Hartel Shabani, and Professor Gail Roseau in the audience. This gives us a unique opportunity to have a conversation between young African neurosurgeons and yourselves. So I'm just going to put a few questions towards the young African neurosurgeons, and I kindly ask if you could respond to their response to it, please. So if I could start with Dr. Dave Manga. Dr. Dave Manga is from Mauritius, having trained in Crimea, and he's one of the WFNS trainees in Nairobi, Kenya, just having completed, and he's on his way back to Mauritius. I kindly would like to ask him if he had what he anticipates the challenges will be when he gets to Mauritius, and what he would hope that the wider community would be able to do to help him run his practice in Mauritius. Thank you, Dave.
Good evening. You can hear me? Hello?
Yes.
Yes, we can hear.
Yes. So from my side, because recently for my thesis, I have just done a research about the assessment of the prognostic score of the CT scan in severe head injury. So from my side, I will take whatever things I have learned from here, from Nairobi to Mauritius. But the thing is, as compared to African countries, the thing that I have seen is we lack what we call the emergency medical services. Because remember, when we get a severe head injury patient, the time to come for the patient from the place of the accident to the hospital, from my research, around 75% of my patients that I have analyzed, they came more than 8 hours. And when they came more delayed, the rate of mortality in my study had been 67% as compared to previous studies which was done locally, where the rate of mortality was 33%. And even in international study by Anderson et al., it showed that the rate of mortality was 45%. So the thing is, how I wanted to ask a question from the distinguished professors who are here. How do we address this issue of, from the time of injury, how we can make sure in Africa the patients come as quick as possible to the nearest neurosurgical centers, so that we can provide the essential management for these patients. Thank you.
No, I may be able to make a comment about that. And thank you, Beverly, for allowing me to from the audience. This is the problem of delayed transfer of critically injured neurosurgical patients is not unique to Africa. One of my colleagues did a study of Cook County, Illinois, which is the county where Chicago is. And the average time for transfer from acute subdural to emergency room, not to OR, but to emergency room, was 6 hours. And so we all know this is a golden hour specialty. There's a good evidence base that suggests that having 80% of patients in any given population within 4 hours of emergency treatment will save lives. And I see this particular example that you gave, David, as a great way that low and middle income countries that are just starting the process of organizing their trauma systems may actually be able to show those of us in high income countries that have had a fairly haphazard and iterative approach to trauma systems a better way. For instance, NSOAPs, National Surgical Obstetric and Anesthesia Plans, are informing the best way, the optimal way to treat trauma patients, neurosurgical and other, pre-hospital, in transit, and in emergency departments. And a country like mine, which is the United States, can really benefit from that because we have so many systems and competing interests already in place that a very clear indication of organized management may be exactly what we need. So this is a great example of the benefits of bilateral conversation, that places, in fact, that have not had this 20th century history of a patchwork creation of a trauma system as soon as technology became available, may actually be able to teach us better ways of organizing it for the good of people everywhere.
I absolutely second that. In Sweden, they ran a simulation on out-of-hospital cardiac arrests and looked at ambulance dispatch time. And because basic life support is mandatory in schools, they actually used drones to deliver defibrillators to the site of the cardiac arrest. And so it was basically, they looked at all the sites of cardiac arrest the prior year, and then ran the simulation where they dispatched drones. And it actually shaved off, I remember, 18 minutes in Stockholm, which is not a very big city, from delivery. So, and they have an app which, for example, a 911 can activate if there's any specialized provider in the area gets alerted to where an incident might be. So we might see a lot of use of advanced technology, because at the end, there is simple resuscitation at the scene that is required for the vast majority. I mean, unless it's extrication from a car or so.
If I can say something, I will go against the flow. I cannot agree more how important is the pre-hospital care for our patients. We all know the results of a patient who is hypotensive, with poor breathing, anything. We all know the ABCD or whatever you want to call it. But I've been traveling in Africa, I've been traveling in Vietnam, Cambodia, Malaysia, Indonesia. There is a huge risk. If we talk about a proper pre-hospital care system, which is difficult to create, expensive, and requires a lot of political decision, the endpoint can be, I've seen it. I don't tell you about something theoretical. I have seen it. The endpoint is, why do we spend money for neurosurgery? Because we don't need the neurosurgical unit until we have a proper pre-hospital care system. So in the other way, we already have a neurosurgical unit who are operating in poor pre-hospital setting. So we have to balance the two requirements. We need a good pre-hospital care system. Meantime, we need to improve the quality of in-hospital neurosurgical system. If we say we want to wait, then neurosurgery is gone. Remember that for many countries, neurosurgery is considered as a luxury. So we have to explain the politician. I have done when I was in Nigeria, for instance, or in Niger. We have to explain the politician how we can combine these efforts and moving together, not waiting for the first one to be settled down. Because if we do like this, we don't go with the willings of our surgeons. You have seen in Tanzania, Uganda, everywhere, there are already neurosurgeons taking care of trauma. So we need to parallel. Putting too much emphasis on the first step will mean we stop there until we have finished. And this is bad for the whole community.
If I may just add to that, I think also going back to Roger's comment on collecting data, because the very first line of the guidelines says, for the survivable patient. And we've always assumed in the US, in the West, a Glasgow of 3 with at least one reactive pupil is a survivable patient, that I think in the absence of pre-hospital care, we should probably search for what is the lowest threshold of what is a survivable, viable patient in these conditions. And we have a paper coming out where we've been able to parse that the additional mortality that is contributed to by absence of pre-hospital care is in the vicinity of 24%. And it is the same that is also excess mortality from gaps in hospital care, which is 24%. So I think to also decide that we're not going to treat the same patient everywhere across the world, given different factors of pre-hospital levels of pre-hospital care.
Thank you very much. I'll move on to Dr. Rodney Mwesige Mugarura. He is an orthopedic spine surgeon from Mulago National Referral Hospital, and he's a senior lecturer at Kabale University in Uganda. And this question, I'd like him to share his experience about training for spine in Uganda, and to ask what questions he would like to address to Mr. Trivedi and Dr. Hartle, who are very experienced in.
Thank you very much, Beverly. Training spine surgeons in Uganda is not a very easy task. I would say we've been training spine surgeons for about a little over 12 years. And this is because of pioneering work by our mentor, who was trained in South Africa under an AO Spine Fellowship. And upon his return, he started a spine unit at the National Referral Hospital. Spine unit that all our orthopedic residents rotate through, and even some of our neurosurgical residents rotate through. We also have opportunities through networks that we've made to have some of our residents go and train in Canada. Some have trained in South Africa, some have trained in India. So we have a structure that is working. Of course, we channel out very few people, and we're looking forward to more collaborations. My biggest issue with our training is, like one of the slides showed, we don't really have evidence-based guidelines on which to train our residents, local evidence to guide our training. Most of what we rely on for training will be things that we've read in international journals, experiences that we've picked from overseas. I then would like our panelists to advise, how do you, in a setting where people are very busy and they want to engage in the rigor of collecting data and developing evidence guidelines, how then do you set a platform that can guide training future surgeons so that we can have solutions that are cut for low and middle income countries?
Mr. Trivedi, would you be in a position to answer, followed by Dr. Hartle?
Yeah, so one of the things I think is very clear to us in Western training programs is that as well as our clinical skills training, skills acquisition, I mean, we are focused in training about skills acquisition, and that's quite right and proper. But I think most Western neurosurgical training programs recognize the equal importance for research training within those programs to augment that skills training. It's something that's required in being a full sort of neurosurgeon or full clinician dealing with neurosurgical pathology. It's not just about the skills, it's about knowing that the skills you're applying and the patient in which you're managing is the best you possibly can. So I think when you can start training from its infancy, you can ingrain that within a training program, embed that. And unofficially, certainly in the UK, research training within neurosurgery is sort of thought of as a milestone that has to be achieved. In other programs, you know, it's embedded as a requirement to succeed to completion. So one of the things we try to instill with the Zambian program is for the trainees to understand that actually it's an absolutely essential part of neurosurgical training to understand what's appropriate for the environment that they're in, using the information that others have developed around the world in high and low income countries. But in order for them to develop their own research or evidence base, it does require them to look at what they are doing. And if you can start embedding that into training programs right from the outset, then it becomes the norm for that generation, the generation after, and the generation after. I think the effect we are likely to make in this first generation trainees is the hardest effort we'll have to put in. Once we train those people who are going to train the next generation, it will become a lot easier. But it's to embed that mentality within the infrastructure of a neurosurgical training program, I think, is the key thing.
Yeah, it's Roger. You know, these are all really good points. The comments that I would have are maybe more questions than really answers. I would ask the question. I mean, your question is really in terms of training, curriculum, and then data collection and outcome assessment. When it comes to training and curriculum, my question would be, what's the role of COSEXA there right now? Is there curriculum for spine surgeons that's relevant for orthopedic and for neurosurgical spine surgeons? And if not, is that something that maybe we should all work on together? You know, together with FEANS, with I know Eurospine has a curriculum. Other big organizations in Europe, North America have very successful attempts to implement curricula into training. AO Spine is working on the curriculum right now. So maybe something to explore going forward to really partner up with one of those organizations, maybe under COSEXA to really develop a curriculum. And in terms of the outcome assessment, I mean, that's what we're doing as a partnership now between Cornell and MOI, and Ricky is doing that in Zambia. Again, I mean, I would encourage reaching out to FEANS, for example, to see if there's an institution in North America or somewhere else or in Europe that is interested in working with Uganda to maybe put together a data collection, a database, a registry similar to the one that we're using in Zambia or in Tanzania. And but I think that the key is partnership, and the key is really initiative and approaching those organizations. We've got all these organizations that want to help. NAS approached me recently, and we want to start a grant round process with NAS, where NAS spine surgeons give every 6 weeks or so grant rounds that are available for East African surgeons. So there are a lot of opportunities, and I think that if you wanted to reach out to any of those organizations, that would be a great start.
So thank you very much. Yes,
sorry, I have one question to answer. Sorry, because then I will not have the possibility. There is an important question about training supported by World Federation, who is closed since March 2020. You understand, all of you, the issue of COVID, and we had an unfortunate episode in Europe and another one in Africa. Then we had to stop. You understand that moving people in different countries in this moment is difficult. And then now in Europe and many other countries like North Africa, we have a second wave of COVID. I am very sorry for the people who are waiting for applying and training. We will be able to open in safety as soon as possible, but they asked me a date. I don't have the date. If I can tell you when this nightmare will go off, I will get the Nobel Prize. I don't know. Simply, I don't know, but we will do from the WFNS side the best we can to reopen our training programs as soon as possible. Sorry for the interruption.
No, thank you very much, Prof. The time has quickly run and it's time for the next session. I do hope, as one of the young African neurosurgeons, that we can organize other sessions where we can have an exchange of ideas between yourselves, Prof, the professors, and young neurosurgeons who are starting out, many of whom are either pioneer surgeons or lone surgeons within their countries. So over to Dr. Shabani, who at his time also was a pioneer in many ways.
Yeah, thank you very much. So this session is, so we finished this session and we invite Ingaya to lead us through.
So I'd like to invite the first presenter who is going to moderate this, our final session, Dr. Shabani. You're the first presenter. Dr. Shabani is the chairman of the Department of Neurosurgery. He's going to take us through neurosurgery in low, middle income countries. A life journey. Karibu.
Awesome. Good evening, everyone. I think now it is evening for everyone, and good afternoon to some of our fellow up there. Yes. I was asked to present a very difficult topic. I don't know whether it will be what I'll be saying is representative of all the low and middle income countries, but I will reflect mostly on our experience in Tanzania. I'm the head of neurosurgery, FEM 1. In our institute, we have 2 units, so I lead one of them, and the other is led by my colleague. I think each one of us who have trained abroad, this is this is how we feel when we get back home. That we assess ourselves whether we fit in or we are outliers. And the fact is, when we check on the World Federation Neurosurgical Society's workforce map of 2016, it shows very few neurosurgeons are located in Africa. So actually disfiguring the map, if you locate 1 surgeon per every 100,000 neurosurgeons, you find a country like Tanzania, we rank at a very low level of 0 point something per 100 population. And this is a fact we know. The disease burden, neurotrauma, is still a big burden. Pediatric hydrocephalus, brain tumors, and the priorities have been training equipment, and this has been known very long during the brain decade in 2001. Another thing we find ourselves in dilemma is okay, you are there as an expert. Where are the supporting staff? Are they capable to support you, actually? I mean, the radiology, the pathology unit, the ICU, the emergency department nurse and staff, the junior doctors. I mean, all this is a dilemma. Equipment and supplies. We know neurosurgery in this part of the world is a luxury because emphasis has been put on other fields, especially the communicable diseases. And then if you come to surgery, the NSOP, which was inaugurated in 2015, emphasis has been also to other types of surgeries, not neurosurgery. So you find the system for equipment and supplies is not in favor of neurosurgery. The training of other staff, how do you train them for you to cope with whatever you want to start as a project in your country? I mean, for instance, the neurotrauma, for instance. And then we have discussed this much, research and development. I shouldn't repeat much. I mean, evidence-based medicine. So which one do you rely upon? Should we rely on how the first world treat the neurotrauma cases, or we need our own model, which is not even available? And then the skills. Some of trainees from other first world, it's not upcut skills where someone is left to jungle around the bush alone. He needs a mentorship. So where do you get this mentorship? Immediately from school. And the government support, as I've already mentioned. So you find most of the surgeons who arrived in the early 70s in Africa, if I will show you in Tanzania, the only solution is to seek help. And the immediate solution you seek from your local peers where you are located. And most of the neurosurgeons who come to their local institutions, they are located in the general surgery. This is where they start their neurosurgery practice. And you can imagine a department full of general surgery burden from rupture abdomen, chest, and all these other pathologies. You put on top a head injury with a mortality of more than 60%. You can just imagine how they will call you. You are an outlier. You'll just be there, very far away. The government bursary I've already mentioned. How will they help you if you don't have evidence, data to show them that this is important? International collaborations, if you are lucky, you can get one. We thank very much for the international collaborators since the brain decade in the late 90s, that the emphasis has been to improve the neurosurgical practice. I shouldn't underrate that one. I thank you all for assisting us. So this is where we are now. The Muhumbili Orthopaedic Institute in Tanzania is located at the eastern coast, as shown in the map. We are 10 neurosurgeons. We have 5 operating rooms. We have 36 ICU beds. We have 70 inpatient beds. We have a training school. We are registered as a training school under the university where we train general surgeons to acquire Master of Science in neurosurgery for 4 years. We are also a training site for neurosurgery and orthopedics. We have entered international collaborations. Like currently now we are with the Weill Cornell Medical College. We have also enrolled ourselves as a research center for a number of groups as listed down there. We also just recently with our current government, I will show you later how we have influenced the politicians. We are now running satellite departments, 3 satellite departments in the north, around the Lake Zone, the northeastern, and the central, where we have located our neurosurgeons there. They are running a full department there, and we have also a visiting center in the south. We do a 2 weekly visit there to do some brain surgeries, mainly the pediatric hydrocephalus and neurotube defect. In Tanzania, in 1960, neurosurgery was non-existent. In the 70s, there were humanitarian missions from abroad, mainly from UK, Ireland, Cuba, and China, who were doing sporadic procedures, mainly brain tumor surgeries and intracranial hematomas, but literally no spine surgeries. And a few of VP shunts for hydrocephalus and spinal bifida. In the 1980s, there were 2 local specialists who were trained from Europe who joined the Department of Neurosurgery. And this is when we say there was an establishment of neurosurgery unit. And they shared a 5-bed, which was for the whole hospital, catering for all the surgical and obstetric cases and medical cases. And at that time, there was no CT scan, And most of the patients were being referred abroad to Germany, especially the brain tumors and the spine degenerative procedures. In the 90s, there was a Swiss foundation collaborating with the orthopedic unit. And at that time, there was the political will to reduce patient referrals to Europe for external fixation of the open fractures and osteomyelitis in Tanzania. And there was an AO ASIF program where Transfix, if we may remember the Dispofix, which is currently in the market, the first research was done in Tanzania, and it was coined as Transfix, where you find a shunt screw with the perforator placed in the front. So it is a one-unit system, lowering the cost of procedure. At that time, the government bought a CT scanner, which was only located in Dar es Salaam, and Master of Science residence program for neurosurgery was started as a sandwich program with the assistant of Swedish Orthopaedic Foundation, and 2 more specialists graduated. And this is the time in 1996 when the Muhumbili Orthopaedic Institute, comprising orthopedic department and neurosurgery, was started. So I would say the rebirth of neurosurgery, which we are happy to see today, was born after 1996, when Muhumbili Orthopaedic Institute started. So the 4-people unit of neurosurgery was performing basic neurosurgical procedures, traumatic brain injuries, 30 cases per month, degenerative spine without instrumentation, at least 10 cases per month, hydrocephalus and spina bifida, almost 10 cases per month, brain tumors, surgeries under microscope, around 5 cases per month. Those were general cases. Challenges at that moment were the implants, especially the spine implants. Spine implants were something of no mention in this part of the world. The Sagicil, the bone wax, those were not available at that moment. They were very expensive. We got in 2000s, Madagascar Africa, FIENS, Canadian Network for International Surgery, collaborated with MOI, and this is when we saw enhanced international humanitarian missions. The task shifting model came about. You see some articles in the journal talking about this task shifting and the controversies underlying that one. And then there was one neurosurgery satellite center 600 kilometers away in the north, which was also established at that time. And these are the papers I wanted to share with you, which were published at that moment. And then it was very clear that there was a need to establish database to inform policy and to develop neurosurgery in a proper way, following this influx and enthusiasts of collaboration. And scope and review research was emphasized. So at the same time, Weill Cornell Medicine from New York, Professor Harto, Professor Stig, and the team from US made a very comprehensive collaboration with MOI, and a 6-point plan was clearly underpinned. The international mission, once a year, to perform complex surgical procedures, minimally invasive spine with 2D navigation, epilepsy surgeries, skull base aneurysm surgeries, were initiated. And then there was the two-way exchange fellowship program, which was initiated. And the essence here was to impart knowledge and skills and attitude towards proper neurosurgical services of patients. Our residents could go to New York, stay there for 6 months, and residents and fellows from US could come and stay in Tanzania for 1 year, assisting in the database and also scoping review and developing treatment protocols. And then we established also a neurotrauma and neurocritical care course, like this one, which we are conducting today. This is the 7th round since we started this program. And in these courses, didactic lectures, dry lab, and live surgeries are performed hand in hand at the local setting to impart knowledge to the junior doctors, to the surgeons and junior doctors. And a weekly follow-up on telemedicine was also started. And this helped us a lot because difficult cases were set aside for discussion with experts from abroad. Roger Hatto, thank you very much for spearheading this. And it has been very fruitful for spearheading all what we are doing at MOI. In database and audits were put forth, and several publications were on PubMed currently right now. So just to show a little bit what the neurotrauma caused, apart from what I've said, several questions have been asked. How can you meet and how can you cut across imparting our thinking to the politicians for policy change? This is what the neurotrauma course in Tanzania has done. With communication skills and vigor of the local surgeons and our local collaborators. You can see here on this picture, Professor Stig and Professor Hatto was just behind me there. And here we are talking to the president at that time, president of our country. He's retired now. And you can see also here, this, on my left side, this is the director of finance of the institute. So you can just assume what were we talking about? Getting more resources and making things robust. On the right-hand side, you see the inauguration of the last year's neurotrauma course. The most important thing in these courses, we always invite top leaders. So in this last year, the chief secretary from the Ministry of Health inaugurated the conference, and he got a chance to listen and he got a copy of manuscript of all what was presented. And this is how we managed to achieve all this, what we have right now. So far, we have 18 publications in the peer-reviewed journals from this collaboration. Our local neurosurgeons have acquired recognitions in international bodies. I thank you. I'm also a recipient of that. I thank you all for understanding and accepting us. I'm now the member of the Neurotrauma Committee of the WFNS. I collaborate with the Cambridge in the genus studies, and now we are entering into NHR Global 3, and this is how we are going on. My fellows have also been recognized in the AO spine and the AO neurotrauma. We have participated in the multi-center cohort studies. So far, 2 studies. We're entering into number 3 on the neurocritical care protocol. we have trained our fellows from COSEXA region, 4 fellows in this training institutes. And as I said, we have expanded our neurosurgical services outside MOI in Zanzibar, Bugando, Arusha, and we have acquired more resources and support from the government. To mention a few, we have now a spine trauma registry. I mean, we have a robust spine trauma surgery which is offered free of charge, because based from the trauma registry, based from the spine trauma registry, which we are actively engaged in and collaborating with Weill Cornell. And complex neurosurgical procedures now can be performed by local neurosurgeons and with guidance from consultants abroad. To mention a few I've just shown you, and very soon we have acquired an in-house MRI and CAT lab, and very soon we shall start on endovascular surgery. So you can see how fast we are moving after involvement of politicians in the resource allocation. So our vision is to change the world map from the neurosurgery, from the neurosurgeons distribution of 0 to 100 per population and make it better. So if we become an epicenter, that will be very effective. And we have seen that our hybrid model with Weill Cornell is very fruitful. If we become a center of excellence, what are our expectations? We shall envisage production of neurosurgery protocols which are unique for low and middle income countries. And manpower will be equipped with local skills. And research and development will be accelerated in this part of region. And services will be closer to people, and there'll be no referral abroad for unnecessary cases. So in conclusion, developing neurosurgery in low and middle income country is challenging, of course, but with networking, sharing experience, and perseverance, this can be possible. Thank you very much. Just before I conclude, these are the few pictures I wanted to show you. On the left, this was a team from FIENS, visited MOI when we started endoscopic pediatric neurosurgery. The next picture, you see Professor Rowling, who taught the 2 neurosurgeons in 1996, Dr. Kinasha and Professor Kahamba. And you can just find me there. This is when I was just immediately from school, where I trained neurosurgery training. And the other one is when I visited Weill Cornell during my fellowship training, and I had a chance to do robotic surgeries and also laboratory procedures. The other one is Madagascar, Africa. And yes, we followed with Madagascar, Africa when they introduced X-leaf procedures here at MOI. So thank you very much.
Next talk will be on volunteering and education in global neurosurgery. Our speaker will be Dr. Gail Rousseau, who is a clinical professor of neurosurgery at George Washington University. And she's also chairman of WFNS WHO Liaison Committee. Welcome, Dr. Gail.
Thank you very much. It is a pleasure to be here with you. Can you see my slides all right and hear me all right?
Yes.
Great. Okay. Well, as a courtesy to others, I'll try to start right on time and end on time. It is really an honor and a privilege. Thank you very much, Dr. Hamisi, Dr. Hartle, all of you for inviting me. And you've assigned me a topic near and dear to my heart, which is about global neurosurgery and specifically today, volunteering and education. I have been to MOI and it's a pleasure to be with you all again. Thank you for the warm reception you gave me when I was there, and I celebrate your great progress that Dr. Hamisi just showed us, and I really hope to see that continue to grow. So, you know, we're talking about global neurosurgery a lot these days, but in fact, neurosurgery has always been global, right? I mean, you see just from these flags alone, some of the leaders that we all refer to in our daily practice, we're always from all over the world. So why this focus now? What is so new about global surgery in recent years? And I hope in the next 10 minutes to share a little bit about that with you and make the case that there's been a profound change in our culture and broad participation in global neurosurgery, which is requested by both our junior members of our community, embraced by seniors. And I think it's really a fairly profound change that has happened in the last 5 years, and that many of us now consider that in addition to our core responsibility of taking the best possible care of the patient in front of us, we now have an additional core responsibility as neurosurgeons everywhere. And that is that it is our duty to advocate for access to high quality neurosurgery for everyone, everywhere. It doesn't mean we all need to travel, but we all need to be part of advocacy for high quality neurosurgery for everyone. It is not a luxury. It is basic. So you know about the World Bank Challenge that started, and here is a great example of what happens when physicians are put in government positions. You have physician Jim Kim, who becomes World Bank president from his work founding Partners in Health with Paul Farmer, his med school roommate. He knows that surgery is the neglected stepchild of global health. And so he issues this challenge, and we have the Lancet Commission, that seminal paper. And from that, we can derive these fairly compelling two statistics: that every year, right now, 5 million unmet neurosurgical operations, these are emergency and essential operations, are occurring, and that we currently need 23,000 additional neurosurgeons. And the great news is that neurosurgery has really been in the vanguard of scaling up and leading the way in global surgery. I'd like to share with you about this change in culture that has really been pervasive in every aspect of what we do globally, up and down the hierarchy in neurosurgery. So we've had volunteering and collaborations that have been housed within academic facilities, within professional associations and organizations, governments of health, faith-based organizations, and industry of health. And in these brief 10 minutes, I'd like to just give you kind of a sampling of what is going on and ways to get involved. That's the charge I have this morning. This picture was taken at Weill Cornell, and is a great demonstration of the fact that global neurosurgery is a rapidly emerging focus of concentration for both individuals and departments. We have had great leadership in North America, but throughout the world. But in North America in particular, our leaders of the AANS and the CNS have embraced global programs on a widespread scale, as have the editors of all of our journals. Each one of these individuals has embraced the concept that global neurosurgery is important. Peer-reviewed journal presentations are important. And as a result, you see a bar graph like this. So here you have Jim Kim, who was the main speaker, the Cushing orator at the very most recent time we were all able to meet together at the AANS in 2019. So imagine that we had a World Bank president speaking to neurosurgeons, but it shows how profound the change in focus and how pervasive the embracing of global neurosurgery has been. So this is just a snapshot taken from where I was sitting, but this is the slide that he was showing that documented this major increase in publications. And if you looked at this same graph for 2019 and 2020, it would be off the slide. And I'm very happy to see that MOI is contributing mightily to that, as we just learned from Dr. Hamisi. But everyone's involved. If you look at prevention programs, Think First, these are the presidents of Think First currently, and the next two slotted to be in the driver's seat for Think First. And all of them have championed international neurosurgical participation in neurotrauma prevention, so that we now have Think First prevention chapters in nearly every state and nearly 40 countries. We have the US government that's embracing this as well, so that we have Fulbright fellowships. You're all familiar with that. These are bilateral exchanges that have been available with US government funding since the 1950s. And this year we've had our first neurosurgeon Fulbright fellows. So on your left, we have Becca Reynolds from Vanderbilt. On your right, Rebecca Garcia from Northwestern, who have spent their Fulbright years in Zambia and Peru, respectively. This is where our focus is going, and our young people are driving that movement. Now let's just pause a moment and think about those numbers I started out showing from the Lancet Commission. We know that there are millions of people right now who need neurosurgery around the world. We know that we need to train tens of thousands of additional neurosurgeons, and that if we don't, there will be trillions of dollars in GDP losses. And yet we also know that every year from high-income countries, there are several thousand healthy and experienced neurosurgeons who either reduce their activity or retire every year. So this brings up the idea of the seasoned neurosurgeon. And we were asked to write an editorial about this concept in Encore Careers. And we have no better example than Bill Gates, who spent his career famously creating and growing Microsoft, but at age 53, stepped away from it in order to have what he has widely reported he feels is a more substantial and satisfying career, and that is his philanthropic career. So here you have people who are still practicing, myself, Scott Robertson, Sandy Lamb at Northwestern, but who are working now to be able to have very robust activity when we're not taking night call or seeing patients every day. Neurosurgeons are now involved in policy, something that wasn't happening 10 years ago. So now you have this specter of neurosurgical delegations of up to 20 neurosurgeons who, on their own nickel and on their own time, go to the World Health Assembly in Geneva and meet directly with ministers of health and help direct policy. Just like Dr. Hamisi showed us, that makes a difference. And then, of course, when we do these things, then we write them up and communicate them in our peer-reviewed journals. NSOPs, National Surgical Obstetric and Anesthesia Plans, are what have come from the World Health Assembly embracing this concept of global surgery. And Tanzania was the very first nation to come up with its NSOP. I know that Dr. Hamisi is disappointed in its relative lack of attention to neurosurgery, but that's only a matter of time. It's up to us to make the case and to advise governments as to why sovereign budgets need to include trauma care, and that is happening. Here's a great example of some of this activity that's been going on in the last 5 years. This is our paper last year looking at low-income countries that did and did not have published neurosurgical studies. And the sort of the negative aspect of this is we identified those 15 countries depicted here in red that have never published a neurosurgical outcome study. Well, we all know that that doesn't mean there's no neurosurgery being done there, but either it's being done by general surgeons or those neurosurgeons are so few and so strapped with clinical responsibilities that they are not able to take the time to examine and publish their work. So now we have an additional project of reaching out to each of those 15 countries specifically and deliberately to provide the aid that they and their patients need. We also have the development of Intersurgeon by pediatric neurosurgeons William Harkness in the UK and James Johnston in the US, who started out with a vision of connecting pediatric neurosurgeons and have been extremely successful in growing this in just 18 months so that they have had over 600 successful pairings, and they have now included pediatrics, ophthalmology, NGOs, and they're currently working on medical student association pairings and allied health. This is a way to keep connected. We've mentioned FEANS, and FEANS, as small as it is a powerhouse and is the single largest supplier of global neurosurgery fellowships. And we're working now on virtual fellowships so that we'll be able to spend those resources effectively and productively, even during the travel restrictions of COVID. Well, here's a shout out to Roger and the whole team at Cornell who started this ball rolling in January of 2019 when they brought together more than 85 people who were interested in global neurosurgery to share best practices. And we hope that we will continue to have gatherings of this in the future. There are opportunities for new leaders to emerge across continents and across oceans because of the way we can learn through simulation. So in looking at how we could improve clinical skills for neurosurgeons who were coming to Geneva for surgical advocacy, we needed to look not more than 3 hours from the site of the World Health Assembly to find Marc Levivier on your left in Lausanne, who has a great sim lab for radiosurgery planning, or Francisco Demeco and Alessandro Peran in Milan, who at Carlos Besta have a very robust sim center that all of the European trainees use, and they've made that at our disposal. And then, of course, my good friend Carl Schaller, who has a fabulous simulation center right in Geneva that we have and will continue to use when we're meeting in Geneva for advocacy. I mentioned that the FEANS Bassett is looking to 2021 to have a pilot program of virtual fellowships so that we can use a Khan Academy model to continue these kinds of very important one-on-one or one-on-three training programs, even during a period when we can't travel. We're really examining whether in a time when we need 23,000 more neurosurgeons, whether we can afford the luxury of always sending people for 3 months or 6 months or a year to another country. Maybe there's a way to accelerate this process using the combination of online platforms for teaching as well as novel technology like Help Lightning and smart glasses to share operative technology. This is where we're going with this global neurosurgery fellowship. I'm excited to share this idea with you, and I hope that if you're interested, you'll write to me about it and be involved in the pilot that we will have going in 2021. There's ways to be involved through the Global Neurosurgery Committee under the leadership of Key Park and El Wahabi. You can go right online now, globalneurosurgery.org, and see the progress that's being made in coordinating all these efforts so that we can amplify and align our advocacy and our educational platforms. It's been my pleasure to spend time volunteering in Tanzania, in Zanzibar, and some of the most outstanding contributions that neurosurgeons have been able to add in volunteering have led to entire neurosurgical hospitals in Haiti, and then this lovely one in Zanzibar that you know so well. There are committed individuals. You mentioned Dylan Eligala and Madaktari Africa. Sarah Woodrow has been involved with Black Lion Hospital in Ethiopia, Richard Wones in Kathmandu and in the Maldives, Edie Zussman in Nigeria. So the point that I'm making here is that it's not only departments, it's not only big, well-organized organizations, but it's individual neurosurgeons who are making a difference. That's how deep the penetration of this concept of global neurosurgery has been. There are even very ethical ways of being involved in faith-based organizations like Solidarity Bridge, which has brought neurosurgical boot camps to Bolivia and Paraguay. And finally, industry. We have great industry partners who have allowed us to be able to expand our educational reach while also showing them that they have collaborative markets that are just now starting to open up. And then as I begin to close, we have within our own organizations like the RRC, Residency Review Committee, making concrete changes in the way we train residents so that it's easier to be able now to travel internationally because our residents don't need to do it on their vacation time, but they can do it on elective time. And then I just want to be sure that we all are very aware of the fact that neurosurgery doesn't occupy or work in a vacuum anywhere, not at individual hospitals or on the global stage. And so our working with our colleagues in global neurosurgery and global surgery involves the G4 Alliance, which is the major overarching organization that links us all together. And this organization is doing things that we weren't doing before in neurosurgery. We're doing public advocacy with letters in places like the New York Times, or at the UN General Assembly, we're able to get ambassadors and ministers of health to join us and talk about the importance of global surgery. It is not luxury anymore, and we've made that case through these kinds of efforts so that neurosurgery is stepping out of the shadows, as is all of global surgery. So much so that here's a screenshot from just yesterday at the G4 annual meeting, which was online because of COVID. Here is none other than the WHO Director General greeting the members of the G4 Alliance and recognizing, even in the midst of the global infectious disease pandemic, Dr. Tedros recognizing the important role that G4 Alliance makes and that all surgeons play in public health. So to conclude, I just want to thank all of these students. Some of them are on this webinar today. I've been inspired and uplifted by all of these young neurosurgeons who are pointing the way. They are truly the future of neurosurgery, and they have convinced me that our future is global. They're involved in all of these wonderful organizations, notably Incision, and they have shown me the benefits that come back to neurosurgery of global programs. The enhanced use of online resources levels the field. For instance, this is just an example of a paper we published two papers we published recently with people I've not even met in person. That's one of the silver linings of this pandemic, that we can work with people across seniority lines within neurosurgery departments and across the planet in order to contribute to our common knowledge. And in so doing, we build the diversity of our manpower within neurosurgery. And that increased diversity builds strength and resilience in our field. I hope you'll all tune in when Neurosurgical Focus in March of 2021 focuses again on international topics. So final slide, how to get involved. It's all of these things which I've just mentioned, individually, department-wise, with your national or regional organization, with your students, with your government. There's many ways to get involved. We all have this responsibility, and I welcome the opportunity to work with you all on it. With that, I'll leave you with my contact information and my great thanks and gratitude for being part of this tremendous 7th successful program. Thank you, Dr. Hamisi. Thank you, Dr. Hartle.
All right, it's Roger. Gail, it was an amazing overview and really summary, the big perspective really, with your experience, with your really understanding of the complexity of the problem and the context that you have been able to make and also foster, and the friendships that you've been able to develop over all these years. It's amazing to see the work that you have done. And thank you for your shout out of our global neurosurgery meeting. We discussed it, and we have Roseanne and Tatiana who help us put all these meetings together. They're listening, and we discussed that we're definitely going to go ahead. We want you to be part of this in a very, very important way. And Caitlin will be part of it as well. And then we'll be in touch, and we'll probably plan something, most likely virtual, I assume, next year, or a combination.
Well, that sounds great. Thank you very much. And I hope I communicated in showing all of these programs. This isn't showing what I'm involved in. I was trying to show the depth and breadth of neurosurgical commitment to this concept of global neurosurgery and global surgery. Literally everyone from the youngest to the oldest in neurosurgery is interested in becoming involved or already involved. And I'm very proud of the fact that neurosurgery is really leading this charge. So thank you.
Totally agree. Yeah. Dr. Shabani, what's the...
Yes, thank you all. And now we are moving again to the next session. Dr. Roger, this is your turn. We'll be presenting on the ethical implications for traveling neurosurgeons.
Yeah, no, thank you. Thanks for inviting me. I do not want to assume that I'm going to talk about ethics, but I want to talk a little bit about the lessons that we've learned over the years. And when I say we, I really mean myself, of course, but many others who are really instrumental. You know, Hal Mangat is part of this. And he has been part of the success. I've been more part of the problems, and the lessons learned are really more towards me than anybody else here. But the successes certainly are due to Hal, Dr. Shabani, all the others in Tanzania, and our chairman, Phil Steek, who's been incredibly supportive of all the work that we've been doing. But I want to talk to you a little bit more from a personal perspective about the mistakes that we've made over the years, or that I've made. When I got involved with the Tanzania project, which was about 12, 13 years ago, it was really more an opportunity to go there once a year and to operate, maybe teach and train. But initially, the way that we looked at that was really more from a unilateral perspective. What can we do to help them? And that was a very, very short-sighted and really the wrong angle. For example, what we did was we got patient, I got patient donations. We funded containers, we collected equipment without really asking. And that was at Bugando, which is in northwestern Tanzania, a different hospital. And then we also went to MOI, but without really getting feedback from the local institutions to figure out really what is it really that they need. So we kind of spearheaded ahead because we had funds, we had a lot of energy, we had a lot of motivation. and brought tons of equipment that companies donated, all related to neurosurgery in one way or the other, brought it to the hospital. And I remember I was so excited. The container arrived, everything was unpacked, and it's probably still sitting in those crates, and it's sitting in those halls at Bugando, and was never even unpacked. And the problem there was clearly that this was a unilateral initiative. We didn't really talk to the people at Bugando, and they didn't really tell us what they wanted or needed, and we kind of made assumptions. And that was a big problem. There was a huge lesson learned, because then every year we went back there, we could still see those boxes unpacked or partially unpacked. And that was a problem. The lesson that I learned was that, well, you really need to ask first, what is it that you need? And then we have to deliver based on those expectations. Michael Haglund in Uganda has done this totally differently. And I think the work that he does and his group does is really based on bringing a lot of equipment over there, and they do it very successfully because they have that collaboration and they have the infrastructure locally to take care of this equipment. So if you do this type of work, make sure that you really communicate with the local institutions to make sure what do they need, what is their infrastructure, what can they handle and what not. The same with books. We got tons of donations of books from the local library here in New York, the medical school library, from neurosurgeons give us their journals, and we shipped the books over. And what happened to those books? They were all, basically delivered in this room, in this storage room in the library, and nobody ever went through those books. Again, that was something that was our idea. We never asked, do they really need books? And that's what happened. So again, I quickly learned that this is not the right way of doing it. The other problem that we had was we would go over there, we would have an anesthesiologist, a nurse, visiting surgeons, all from Europe, from North America. And what happened was, a bunch of people from Europe or North America, and we spent the whole day together without really interacting with Tanzanians in the operating room. This is a typical example as a surgeon from Portugal operating with a surgeon from Britain. There's no Tanzanian to be found, and we quickly stopped that because we realized if we really go there and we operate, we don't go there to operate because we think it's cool to operate there. We do it because we want to operate with a Tanzanian surgeon, with a Tanzanian anesthesiologist, and we started mixing up teams and pairs and made sure that there was always a mixed group of surgeons locally and some of the visiting surgeons. Now, this is a better example. This is one of our chief residents years ago operating with Tanzanian surgeons here. And so we really tried to kind of mix it up and make this a much more successful experience. Otherwise, you just come out of this experience being very frustrated. Other problems. We had one surgeon join us who thought it was a good idea to do a complex scoliosis operation, and it ended in a disaster because the post-operative care was not really adequate. These patients experience a lot of blood loss. There are a lot of anesthesia-related problems. We didn't think that through. Pituitary tumors, if you don't have the hormone replacement therapy afterwards, it's not a good idea to do these types of cases. And these are all things that we don't think from the Western Hemisphere. We don't necessarily think about these things beforehand because we're used to a well-structured, well-equipped system and infrastructure that allows us to take care of these complex pathologies. Well, in these countries that we go to, sometimes that is not the case. And you have to think about every little step, not only the surgical procedure, but the post-operative care. You have to plan this very, very carefully beforehand. Something that we learned over the years very painfully. Equipment, we brought over drills that were brand new and were then not really functional anymore because the maintenance was not available, or they broke down and nobody was there to really repair those drills. So we couldn't do anything. So that was not a good idea. So we stopped doing that. And bioengineering the lack of bioengineers. One of our most successful trips to Tanzania was when we brought actually a biomedical engineer. He actually ended up spending 2 or 3 weeks longer than us because he was so in demand and he was so busy. That was, again, one of the lessons that I learned. Well, if you can afford it, if you have the availability, try to come with a biomedical engineer because that person is probably needed even more than some of the surgical some of the surgeons that we bring over, frankly. given the challenges that those regions fail. Now, a few other red flags. I know from traveling with a lot of visitors over the years that there are certain red flags, okay? And I want to make this a little bit maybe on the humorous side. So if you travel with some, and the first question is, can I bring my boyfriend or my girlfriend? It's always a bad sign, okay? Because this is not a trip, it's not a pleasure trip. You're not going to the beach somewhere. I mean, you actually go there early in the morning, you stay there until late at night, and then you come home. It's usually not a good idea to bring your significant other on a trip like that. Food restrictions can be an issue. You know, I've had people travel with us who ended up staying at the hotel the whole time because they thought that they can't really handle the food. And then the other thing I see frequently is people who travel and then they always compare us and them. They say, oh, we do it differently. Why don't they do it the same way? What's going on? And that causes a lot of frustration. It also tells you there's really a lack of insight and there's a lack of really understanding of what's going on in those countries. So then the failures. The failures were really primarily due to the inability to really align expectations, that we have different expectations. We who are trained in the Western hemisphere have different expectations. We take patient preferences, it's much more important for us what patient preferences are, for example, and then a lot of the countries where we're trying to help. Failure to understand cultural barriers and differences. And then the failure to act is also a big problem and very frustrating problem. For example, Hal knows this better than I. We've been collecting data on patients with traumatic brain injury for 5, 6, 7 years. And every year the mortality was about 60%. And it just becomes incredibly frustrating to collect these data year after year without really being able to do anything about it. And that can be a failure to act, but it can also be a really incredible frustration. It may lead to a lot of people then deciding, well, we're not going to do this anymore. We can't do this because it's too frustrating. So at the end of the day, we found that it's not really how fancy your equipment is. It's not really what you have and how much you have. It's really how you use it. One year, at the end of the year, I got this picture from some colleagues in Tanzania, and I thought that was really insightful in a way. So the equipment may be very, very primitive. At the end of the day, it's really how you use it. So the goal is not to bring in the most advanced CT scanner or the navigation system. The goal is really to teach surgeons who have a limited access to resources to use those resources properly based on their skills. So for our work then, from the Cornell perspective, the question then was, after all these experiences, well, we can't really only travel 1 week at a time. We can't really go there more. So how can we maximize? How can we have an impact from overseas with this time limitation of a week or maybe 10 days a year? Limited resources, their cultural barriers, their language barriers. So how can we make our goals align between the North American perspective and the Tanzanian perspective? How can we get people to work together, even though all these groups are fragmented? In Europe and North America, there are a lot of organizations, and Gail very nicely summarized that. How can we really try to get these to talk to each other to really work on a common goal? And then the other thing is really communication challenges. And this really has only changed now during COVID. Before COVID, the quality of the internet seems to me was actually worse, or at least the software was worse. Now, this webinar is a perfect example of how we've really mastered the use of virtual webinars and the equipment and the software. 6 months ago, it was very different, or a year ago. So the challenge is, with 1 week at a time, how can you have an impact? It's almost like squaring the circle. So we decided then, well, let's focus on really achievable goals. And the achievable goals were, what we can do is we can help our Tanzanian colleagues assess the current management of neurosurgical diseases without having to change the way that they're doing things. Maybe it's helpful to just collect data, be very humble, try to collect data, and just see what's going on right now in terms of how they treat patients. Develop a close network that fosters exchange, teaching, and communication. That's something that shouldn't be too hard to do. How do you do that? I'll go into that. And then try to train physicians and healthcare workers in best management practices, and maybe even later on implement stepwise and reasonable changes, even though this is really, really difficult. Well, at the end of the day, what we came up with was really this sustainable, what we think is sustainable 7-step program that entails a yearly visit, in this case to MOI. We do a symposium together with the colleagues at MOI, which is exactly what we're doing right now over these 3 weekends. And what has happened really here is that initially 7-8 years ago, it was really us putting together the program. And now all we've done for this webinar now is really offer some of the technical support. We have Roseanne, Tatiana, who've done an amazing job really shepherding this project, but the content and the structure and the organization is totally up to our colleagues at MOI. And that's something that makes me really incredibly happy and incredibly proud, because they've done a terrific job in putting this together. So, and then we offer fellowships. Obviously right now that's limited, but we have, through patient donations, we have funding to send fellows from East Africa, from Tanzania to New York for short-term fellowships. And then we have funding now also to send full-time fellows from North America or from Europe, trained neurosurgeons, to Tanzania to live there for a year, to work there for a year, and to get involved in one way or the other. It doesn't have to be necessarily teaching them the most advanced surgical techniques, but it may be more research-based, it may be more administration, it may be more publications, whatever it is, but to have somebody there for a full year, which is an amazing opportunity for that surgeon, but it's also great for us to have somebody there who we can directly communicate with. So these fellowships are an essential part of the program. And then the research, we talked about that, the spinal trauma research, the TBI research that really Hal has done a terrific job putting together with the research folks in Tanzania. And then our weekly Zoom or Skype calls that are kind of like the glue that stick everything together every week. And then finally publications. And Dr. Hamisi mentioned there have been 18 publications so far that came out of this collaboration, which is great. And hopefully there will be many more. So I think that this is kind of a sustainable program that can hopefully serve as a template for some of the other programs. And we certainly don't claim that this is the only way to do this, but is one way that has worked for us. And taking into consideration the particular limitations, the particular failures over the years. And I want to end it like this. And thanks again for your attention, and I hope for a nice discussion. Thank you, Dr. Hamisi. And
yeah, Dr. Osman. Dr. Osman.
Yes, Dr. Hamisi, thank you. Thank you for introductions. May I take, thank you very much for your nice presentation, Professor Roger Hatto, and the kind of good works you've been doing to Tanzanians and then the global, indeed, is kind of activities which we value, and I think most of Africans and the rest of the world, they value it. May I take this opportunity right now to introduce our last presenter, Professor Laek. He's a professor, assistant professor of neurosurgery at Tikur and Basa Teaching Hospital in Addis Ababa, Ethiopia. Professor Laek, please, welcome.
Yeah. Thank you very much. Thank you for having me and letting me share our experience from Ethiopia. So I'll be talking about neurosurgery in Ethiopia and the value and the benefit of collaborations from Tikur Anbessa Hospital from Addis Ababa University. So let me introduce you to my homeland country, Ethiopia. Ethiopia is the second most populous country in Africa, and it's found in the Horn of Africa. So Ethiopia is well known of its mountain peaks, and it's also well known by its endemic animals like the mountain baboons, and it's also the origin of the Blue Nile. So to start with, I will touch upon the history of neurosurgery in Ethiopia. So the history of neurosurgery in Ethiopia dates back to the 19th century, when the Russian Red Cross missionary doctors used to practice basic neurosurgical procedures in one of the first hospitals in Ethiopia, that's the Minilik Second Hospital. So in the 1970s, there was an Italian neurosurgeon who has been practicing neurosurgery in the northern part of the country by the name of Dr. Mario Manfredonia. And he came to Ethiopia during the Ethio-Italian War, and he used to practice basic neurosurgical procedures, and he used to treat patients. And he was able to represent Ethiopia during the first PANS meeting in 1972 in Nairobi, Kenya. So this is a picture taken during the first PANS meeting in Nairobi, Kenya. So during the 1970s, there was also a Bulgarian senior neurosurgeon who used to practice in Addis. So he was treating brain tumors like meningiomas after diagnosing with carotid angiogram, and also there was a Cuban neurosurgeon who has been practicing neurosurgery at the Gurambessa Hospital. So we can say that modern neurosurgical practice started in the early 90s, when 3 Ethiopian neurosurgeons came back home after being trained as a neurosurgeon. One from UK, Bristol, who is the most senior neurosurgeon, Dr. Tadios. He is also our mentor, and he came in 1991, and he fortunately brought the first CT scan in Ethiopia as a donation from UK. It used to work for some time, but unfortunately it broke, and we had no CT scan for some time. But up until 2006, the 3 neurosurgeons were only the practicing neurosurgeons in Ethiopia. So they were assisted by general surgical residents who were trained for 1 to 2 months on basic neurotrauma surgeries. So we can divide collaborations as local and international collaborations. So after the 3 neurosurgeons came back home, they were able to make a communication with other colleagues, and the first association of neurological sciences of Ethiopia was established in 1993, and it became the chapter member of PANS. So this association consisted of neurosurgeons, neurologists, neurophysiologists, and physiotherapists. So this, I would say, that a formal collaboration within the country. And also we had a very good support from the Department of Surgery at the hospital. So they were really assisting us to like expand the neurosurgical services in the hospital. And also the existing 3 neurosurgeons were really collaborating among themselves to expand the neurosurgical services. So this is Dr. Mesfin Minas, the department head by then, who really helped to expand neurosurgical services in the hospital, and also who pushed and encouraged our seniors to open a neurosurgical training program. So our external collaborators were from Norway, Haukeland University Hospital, and the Federation of International Finns Volunteers. And we also had other volunteers who came by themselves, incurring costs to stay for a few weeks yearly and help us treat neurosurgical patients in the hospital. So the formal collaboration internationally was made by Dr. Zannaber when he wrote to Dr. Kelly at the University of California and he seek out help from them to expand neurosurgical services in Ethiopia. And then Dr. Kelly wrote back to Dr. Zannaber and he mentioned Finns, and he advised him to communicate with the Finns group. So after 4 or 5 years of discussion on how to open a neurosurgical training program, the neurosurgical training program was formally opened in 2006. So this was a strong collaborative effort of Addis Ababa University, our Norway partners, Peace Corps Norway, and the University of Bergen, and Auckland University Hospital, the Finns, and the College of Surgeons of East Central and Southern Africa. So the curriculum was drafted and finalized in September 2005. So our curriculum was adopted from COSEXA. So it involved 5 years of training, and a site visit was made by COSEXA neuro representative. By then, Professor Qureshi came, and along with our neurosurgical seniors, they visited the training centers, and it was approved. Our hospital was approved to be a COSEXA site. So our Auckland University Hospital partners was the first one was Professor Knut, who was a head of neurosurgery at Auckland University Hospital. He was really persistent and encouraging to open the neurosurgical training program, and he was frequently traveling back and forth from Norway to Ethiopia, Addis, and to establish the neurosurgical training program. And he was succeeded by Professor Morton, who was also our mentor and a skull-base surgeon, who was coming every year for a few months and spend time here to do surgeries with us. And also the current department head at neurosurgery department, Dr. Ruby, was also coming and supporting our training program with Dr. Erling, who is also a very good skull-base surgeon, and who is a very good mentor for us in Blackline. So the Norwegian Ethiopian Neurosurgical Training Program was a collaborative effort of all those stakeholders, and it was initiated after 4 years of fact finding. And this is all the finances that was spent on the neurosurgical training program. So it was not only people coming from Norway and spending in Addis for some time to help us, but there were also neurosurgical residents and medical students who come here to see some complicated advanced cases. So it was a win-win type of collaboration. So they also gained experiences in a setup like ours. So we had a very great support from Finns, and the first person to visit our center was John Clark. So he was really dedicated, and he did many procedures, even spending time in the duty rooms and also spending time at night with residents, general surgery residents, and neurosurgical residents. And Professor Friedberg is also contributed a lot coming to Ethiopia for more than 10 years. And Key Park, also who was a mentor to all of us, who visited Ethiopia for more than 10 years, dedicating time in Addis and doing spine surgical cases together with us. And Merwin Began was also had a great contribution. He was the Finns head by then, and he also pushed and also did a site visit in the hospitals to see and to also help us open the neurosurgical training program. Andrew Kaufman also was also coming every year, and Sarah Woodrow is a spine surgeon who is also coming every year and also assisting us with surgeries, and also brought us many spine instrumentation sets to help us with our spine cases. So also Timur Banerjee is also a volunteer who is coming every year, who used to come every year to assist us with neurosurgical cases. So we had also a collaboration with the World Federation, and this is a picture taken in 2012 after a training program which was done on, in Addis with residents, and it was really helping residents and seniors of having a hands-on course. So we established also a Society of Ethiopian Neurological Surgery Professionals. So this was accepted as a full member of WFNS. So we had last time we had our annual general meeting on neural tube defects and possibilities of folate fortification, and it was involving all our collaborators who assisted us in doing neural tube defect surgeries in our hospitals. So these are all the pictures from the panel discussions that we had. So collaborations have helped us in assuring quality. So our collaborators were actively involved in exams, our qualifying exams for our neurosurgical residents, and also research projects are done annually by the graduating neurosurgical residents. So we used our collaborations and our partners to assure the quality of the training programs. So we have also developed a skills lab training. So this is also a collaborative effort of our partners. As you can see, we had a microsurgical skills lab training and also a brain dissection training sessions. So when we see the benefits, the procedures have increased exponentially. When we see the number of procedures, it's not only the number of procedures, but also the complexity of procedures have increased through time, and also the number of residents and graduates have also increased. So now we have, in our country, we have a total of 34 neurosurgeons who were fully trained in the country. So we also have started a skull-base and microsurgery. This is our senior neurosurgeon, who is also a mentor to us, Dr. Abbat, and he is leading the skull-base unit in our hospital. So this is the publication that we released, 100 skull-base meningiomas operated at Black Lion Specialized Hospital. So we also have a south-to-south collaborations with our Malawi neurosurgeon colleague, Dr. Keller. So Ethiopian colleagues go there for some time and assist in surgeries, and this program is supported by the Auckland University hospitals. So what are the gains? So the gains are that the most important benefit that we had from the collaboration and from the neurosurgical training program is that it has now become sustainable, and the surgeries have advanced, and also our research capacity has also expanded, and also like having a training program in the country have significantly minimized the brain drain. So those are the main important benefits of our training program and collaborations. So I thank you, and I conclude my presentation with this. So if you have any questions, comments.
Dr. Mani, can you unmute your microphone, please? Unmute.
Thank you, Dr. Shabani. Thank you, Dr. Shabani. And thank you, the presenters. We have overshooted the time almost by 20 minutes. So can we kindly maybe give a chance for 2 or 3 questions from the audience? The burning one. Can you hear me? Can you hear me, please?
Yeah, I've checked on the chat. There's no question which has been raised. I think people have understood the lesson. But if I ask presenters, Professor Like, how do you see the way forward in developing neurosurgery in this part of the world? How much effort will you put on international collaboration vis-a-vis government support and the local institutions?
Thank you very much, Professor Shabani. It's I see the way forward is like to have evidence-based neurosurgery in our setting. So our practice should be driven with facts, and also we have to like be strong in collaboration. So and the neurosurgical training program and the neurosurgical practice should be really sustainable. So we should be self-sufficient, and also we have to like keep on trying to be more sustainable. So we have also to push our government to really assist us in capacity building, and we also have to show facts and the public health importance of neurosurgery. So I think we should keep on like pushing to be self-sufficient and sustainable, and also base our practice on evidences.
Thank you very much. Professor Roger, any closing remark?
Yeah, listen, I want to thank you, Dr. Shabani, and Dr. Othman, and all the others on the Tanzanian side who put so much work and energy into organizing this webinar. I think it was unclear, how this would play out. I think overall, over the last 3 weekends, we've seen that there was a lot of participation, a lot of really, really good presentations. There were some technical hiccups here and there, but overall, I think it's been really remarkable how smooth things went. And also the quality of the speakers was really remarkable. And I think that we should take this as an opportunity to really, initially, continue then also the collaboration and the communication across those regions. The presentation by Dr. Lecky was really delightful and really informative to find out about what's going on in Ethiopia and how the development went there. Just a great example of how the region really can work together better, and how these types of events can facilitate this collaboration. I think we need to really sit down and kind of summarize all the things that we've discussed over the last 3 weekends, and I'm looking forward to that. I think there's a lot of amazing initiatives and ideas who came out of this, and I'm really looking forward to continue, obviously, the collaboration with you guys. And I want to thank everybody who participated. This was a high-quality event, and I really would like to leave it like that. Before finishing, though, I want to make sure we acknowledge also the supporters of the meeting. We had the AO, NAS, FINS, of course, the World Federation, and we had speakers from most of these organizations also as part of this webinar. I want to thank all of those and the others who really put so much effort into making this a success. I certainly would also like to leave the last and the concluding remarks for you, Dr. Shabani, and your group.
Yeah, we thank all the presenters for their tireless effort. I know that they had other schedules to work on, but they also saw that this is important to attend and also to contribute to sharing the knowledge with us. We thank all of you. We thank also our collaborators, and also we thank all our endorsement boards. And just to encourage all the participants that we do these courses annually, every year in November. So it happened that this time, because of the travel restrictions all over the world, that we saw this mode might be helpful, and we thank all of you for this massive support in attending, and we hope to see you next year in this course again, whether it will be virtual or practical. We thank you all, and see you again.
Thank you. Thanks everyone. Have a good